The meeting will be recorded, broadcast on Parliament buildings and also online. Apologies, none. So we have Alan Chambers, Noel McAllister, Colin McGrath and Alan Robinson have all said they're going to join online. So I see Colin and Alan already there. So we're just going to move straight to item number 5 on the agenda, which is an oral briefing on the inquiry on access to palliative care. So can I refer members to tab 5, where we have a clerk's memo, submissions to the committee consultation from Compassionate Communities and the Trust Bereavement Coordinators and the Patient Compliant Council. That's on page 19. So can I welcome just to our committee meeting Sharon Williams, who's Project Manager from Compassionate Communities, also Thelma Abernethy, Head of Cruse in the north here, and Fiona Gilmour, who's Macmillan Service Improvement Lead within the Northern Trust. So all three of you are very welcome. So we have 45 minutes for this presentation. I'm going to hand over to yourselves just for brief introductory remarks, and then we'll take questions from members.
Okay, thank you very much. And firstly, we'd just like to thank you for carrying out this inquiry. We appreciate the opportunity to present to you today to supplement our written submission. Today we want to speak openly and honestly about a difficult truth. Palliative care services in Northern Ireland are not meeting the needs of our people. We are here today to tell you about our experience, to amplify the voices we've heard and to explore together how we can do this better. Too many people are denied equitable access to palliative care, which is a fundamental human right, leading to needless suffering of patients and families. This service gap echoes across the system, intensifying pressure on emergency services, creating operational inefficiencies and undermining workforce well-being. For the purposes of today, we would like to address 3 key areas: public perception of palliative care services, fragmentation of services, and a whole systems approach solution. Firstly, public perception of palliative care services. We want to impress on you the need for a public health approach to palliative care, one that addresses public awareness and education and requires a whole system approach to care. The Compassionate Communities International Movement is a public health approach focused on improving palliative and end-of-life care within communities. Compassionate communities care for people where they live, work, learn, pray and play. It emphasises a shared responsibility for care. Collaboration between local residents, organisations and healthcare services are seen as critical to enabling support for individuals and families facing serious illness, death and dying. A 2025 position paper, Fostering Compassionate Communities, a call to transform caregiving, dying, death and grieving on the island of Ireland, advocates for a coordinated island-wide compassionate communities response. This report by Queen's University, produced in consultation with the public and people from the community and statutory sectors, recognise that north and south of the border share challenges around death and bereavement. North-South collaboration has begun online in public engagement in areas such as advanced care planning. However, further concerted support and action is needed. Ensuring equitable access to quality palliative care is not the sole responsibility of the Department of Health. It is everyone's responsibility. Dying is not just biological, it's a significant social event that is inevitable for us all. As a society, with the medicalisation of dying and death, we have lost the meaning in normal dying when a death is expected, because it largely happens behind closed doors in hospitals. Whilst it's appropriate for some of these deaths to happen in hospital, much more could be done to enable this to happen in a person's home if that is their preference. A person cannot be simply viewed as an illness. Cancer doesn't just affect an organ, just as dementia doesn't just impair cognitive ability. Advanced illness impacts every facet of a person's well-being, such as physical, emotional, social and spiritual. And we need to be cognizant that this also affects the people important to the person who's ill. Care burden and burnout is well documented, and we know that Carers NI spoke to this a number of weeks ago. Added to this, practical issues such as financial hardship is common. Examples include loss of a household income, travel to appointments, time off work, the cost of running medical apparatus at home and keeping warm. People report feelings of loneliness and social isolation as they may need to withdraw from the workplace, lose their mobility and independence, or may lose their role at home. Sadly, friends and families may stop calling, as they think they're busy with medical appointments and don't want to intrude, or they simply can't cope with the illness and pending death. Professor Alan Kelleher, founder of the Compassionate Communities movement, references the 95% rule. The assumption held within communities is that a person living with advanced illness or frailty spends 95% of their time with healthcare professionals. Conversely, typically they spend 5% of their time receiving treatment and 95% of their time in their home, in their communities. The ageing population in Northern Ireland is increasing, with many living alone only with their radio, TV, or perhaps a pet for company. Loneliness and social isolation are known to be as detrimental to health as smoking 15 cigarettes a day. Secondly, we want to impress on you the impact of accessing care and support in a fragmented palliative care system. Navigating a complex system at a time of crisis further compounds an already overwhelming situation. The person who is ill or the family feel alone and wonder how they're going to cope. They don't understand the difference between generalist and specialist palliative care services, nor do they understand how to contact these services. Many people in the community don't know that their district nurse is their palliative care key worker and what they can do for them, nor do they know who to contact out of hours, or even if there's going to be help available. This complex siloed system often results in poor communication between service providers and patients. Sadly, as a result of this, person-centred care is compromised, and there may not be timely access to care. This in turn causes increased anxiety and frustration with the system. Added to this, there is an extra layer of complexity for people living in rural communities, people with intellectual disability or severe mental illness, and people living in seldom heard communities. To help us understand the scale of need, we can apply a simple equation. The total population of Northern Ireland stands at around 2 million, and we know that approximately 1% of the population dies each year, so around 20,000 will die in 2025. Referencing Marie Curie's research, it is estimated that 1 in 4 who would benefit from palliative care won't receive it. Therefore, it can be deduced that 5,000 people this year will potentially miss the opportunity of holistic care, including symptom management, improving quality of life and a good death. This experience is likely to have a significant impact on the well-being of family and carers. It is critical that the family's mental, physical and spiritual needs are supported throughout the palliative and end-of-life care journey. Cruse estimates that 6 people are significantly impacted by a death. Therefore, it is likely in 2025 around 120,000 people will be impacted with bereavement. The majority of these people will be supported in their communities, and some will require professional help. The public understanding of palliative care and bereavement remains low, and although awareness is slowly improving, many still equate palliative care to cancer or dying. The consequence is that people living with other life-limiting illnesses, such as COPD, dementia or heart failure, whose quality of life may have been improved earlier in their illness, sometimes only access palliative care at the very end of their lives. Some people are reluctant to accept palliative care as they have misconceptions of what it is. For example, the syringe driver is perceived as a form of euthanasia. Palliative care means that all active treatment will stop, and there's a reluctance to start morphine for pain management for fear of becoming addicted. Aimed at improving health and death literacy, one important initiative is the development of the 12 death-positive libraries in Northern Ireland. They host resources on dying, death and bereavement, which includes easy read and children's books. This initiative is reliant on charitable funds and requires mainstream funding. There also exist significant gaps in bereavement education and awareness across many sectors. Marie Curie's report, Compassionate Schools Communities, highlights the profound impact that bereavement can have on young people. It reveals that 78% of school leavers who have experienced loss struggle academically, face challenges with their mental health, and may exhibit worrying behaviours. Creating environments that guide our children through palliative care, dying, death and bereavement is essential for nurturing resilience in our future generations whilst protecting teachers' well-being. National Lottery has funded Cruse to develop a range of evidence-based intervention on bereavement for children and young people, which they deliver in schools and in community settings. It is critical this work is mainstreamed for funding. Recently, the Northern Trust has established a Compassionate Schools working group to bring together all the stakeholders to explore this work further. Marie Curie reports that 73% of people in Northern Ireland are unfamiliar with the term advanced care planning. To help address this, Compassionate Communities has been developing or delivering advanced care planning events in communities for 3 years. We are aware that healthcare professionals has already addressed the clinical component previously, yet 3 years on, the Northern Ireland Advanced Care Planning Policy for adults has yet to be implemented alongside respect. It is our experience that people often worry about the financial and legal components of advanced care planning. Complex legal terminology and confusion between different jurisdictions is a real barrier to people putting their house in order, such as writing their will or appointing their power of attorney. And there is, of course, the reluctance to engage with this taboo subject. However, we find that given the opportunity to talk about end of life through creative engagement, people find their voice and the chance of working through very challenging emotions. Some people are proactive. Compassionate Communities regularly receive requests for information on advanced care planning. We have delivered numerous sessions. Some examples include people living with dementia, Parkinson's and MS, frontline staff in the homeless community and healthcare professionals. It's imperative to embed advanced care planning discussions into everyday life before a health crisis hits. Thirdly, we are hopeful through a whole system approach that there will be a solution. Action and accountability are needed to implement recommendations in pre-existing and relevant reports to meet current and future need. To achieve this, we recommend the following. Palliative care and bereavement services are prioritised and funded as an integral part of population health and well-being. A whole system approach that is governed and mandated by a regional palliative care strategy. Improved integration between government departments. Full implementation of advanced care planning that invests in public education. A public health approach to palliative care that delivers coordinated regional and all-island awareness campaigns. Sustained investment in community organisations and support for unpaid carers, recognising them as essential providers of palliative care and bereavement support. Adopt the Compassionate Civic Charter as part of the wider palliative care support infrastructure that provides public leadership, shared accountability and co-production. Facilitate a regional Compassionate Communities programme that enables the development of compassionate community hubs in each trust area. We are hopeful that as a result of this inquiry, available measures can be immediately implemented and that a long-term strategy can develop a more equitable access to palliative care for everyone. In conclusion, we would like to reiterate that individually and collectively, we are responsible for ensuring that expected deaths are experienced as good deaths. Just as it takes a village to raise a child, it takes a community to care for the dying. Thank you.
Thank you very much, Sharon. That was very, very useful. We learned a lot of, or heard a lot of stuff there that maybe perhaps we hadn't heard previously. So again, thank you very much, and thank you all for your contribution and for coming before us. You kind of finished there with what you want to see moving forward, and you talked about the whole system approach. So in terms of like the community sector, you know, how can the health sector, or what role do you see for the community sector in the whole system approach? How can the health sector work with the community sector to ensure that we have the whole system approach as you're talking about moving forward?
Well, I mean, there's actors within the community sector that are already delivering on like chronic pain, pain management and other health well-being initiatives that perhaps with a little bit more support and funding and security, their services could be extended because they're in the communities. You know, we have some 30 healthy living centres within Northern Ireland. So they're the ones that are the operational arm. But they need the support of the specialist services. They need the support of education of what bereavement looks like. What they can do within their local residents to support people to live as well as possible up until the point that they die.
You talked about the Northern Trust in particular, about their model. Can you give us a wee bit more detail, just the kind of the work that they're doing, and if it's something that could and should be shared beyond the Northern Trust area?
I suppose, so I work in the Northern Trust, and we set up a compassionate community steering group in 2017 with a wide range of key stakeholders from community, voluntary sector, also statutory. But we have used a variety of methods to try and get the message out, so very much linking with our community groups, say with Arts Care. Sharon has mentioned the creative message, so we've used local author again to try and get the message out about the importance of planning ahead, planning for the future. A playwright as well, we delivered a play there very recently. It was Dying Matters Week. So we're trying to use a variety of methods, but I'm trying to support the community sector, but we have a very finite resource, and this really does need resourced. I'm not sure that all colleagues in the community sector have the confidence. They can talk about diabetes and obesity, things like that, but whenever you go to actually talk about death and dying, nobody wants to mention the D word. There is a reluctance, so again it's about growing that confidence. Health cannot deliver this on its own, and that's, I suppose, very much our collective message, that we need to be working together, we need to collaborate. But again, there does need to be investment and folks skilled up to deliver that message.
Thank you very much. Linda?
Thank you very much. Apologies that I'm not there in person today. I took a wee tumble down the steps of Stormont yesterday.
Oh dear.
But that was a very interesting presentation, and I suppose there's a couple of things in it that we haven't heard yet, Chair, which I think is very helpful. But one of the things that I probably was aware of, but haven't heard anybody mention in terms of presentations yet, is that piece that you have talked about in terms of the education and our children, and what has been delivered in our schools around preparing for death, but also that piece around what happens after a child has been bereaved and how they're supported in school, and because we all know what we're like as a people. We're great, and we're great at rallying around, and everybody will be there for that family at the time of the wake and the funeral and all the rest. Not so good at being there during the lead up to death, and then life goes back to normal for everybody else, but not for that child. And I suppose it's really making sure that there is something in place, and we have had some really good examples in our schools, also delivered by the Education Authority, but I do think this work needs to be done, as you've just outlined, in collaboration. So I think, Chair, maybe we need to get a sense from the education end of things, what exactly is being provided at the minute, what collaborative work is happening with the voluntary community sector, such as the organisations that were been presented to by today, and just getting a real understanding of that. And if you are able to give us any sense of that, because this is not just something that anybody can deal with, because you said a word that I think is extremely important, and we need to never forget in this: resilience. This is not just about letting children grieve, it's also allowing them to grieve in a way that allows them to become a resilient young person that can grieve very openly and freely, but they can live after. And the other thing I think we also should just worth mentioning, we need to remember there are children in our schools who are palliative themselves. So it's how what is in place for those children as well.
Yeah.
And their peers.
Maybe if I come in there, we have a service which is funded through National Lottery, and we go into schools. Sometimes the schools will bring us in after they've had a number of deaths, either of parents, grandparents, or maybe even children within the school, whether sudden, unexpected, or they knew the death was going to happen. But also we work alongside the Education Authority's critical incident team. So if there is sudden unexpected death within the school, the critical team will go in and do what they have to do, and then they would ask us to come in and spend time in the school. So we will go in and do work with the teachers, provide them with a 90-minute session on understanding bereavement, one about how they look after themselves, but then how do they actually care for the children and young people within that school. And then we will do sessions with whatever classes have been affected. So we've got Grief Ally and Grief Buddy, and these services have been developed with young people. So we've got a youth advisory group who have helped us to develop these services, and everything that we deliver has come through that youth advisory group. And those are the supports that we're providing into the schools. We also provide it into communities where there's been sudden unexpected deaths through community groups, sports clubs, etc. as well. Has been funded. These services have developed over the last 20 years, completely funded by National Lottery. We have not been able to get them streamlined, and there's a real need. So there is to get bereavement, but I actually think after doing the work in and around this palliative review, I think it needs to be death, dying and bereavement. The three needs to be put into the curriculum. We have worked with Marie Curie. We were involved in the initial pilot sessions going into the schools in and around bereavement, and that's where the learning came from. And now Marie Curie, with a number of other organisations, we're trying to actually get it into the school curriculum. But I think we actually needed to widen it out to being death, dying and bereavement, because when death and dying is managed and it's inclusive, it'll make that bereavement journey a lot easier. And I think I will be going back to have a conversation with Marie Curie to see, can we actually try and widen that out, because we need to bring it in, because children are going to be impacted by bereavement at some stage in their life, and we need to ensure that those supports are there.
Chair, just thank you, because you've kind of answered the question that I had said we should ask education. I'm aware of the critical incident team. I wasn't actually aware that it was yourselves that went in. I know the work that happens and how good it is. Wasn't actually aware that it was yourselves, so that's actually really helpful even to know that. And I've used a lot of your tools with people, with constituents who've come to me, and families who have children, in order to support them. So I can tell you, I can attest to the amazing work that is done in terms of that, even with other children who maybe are not bereaved in that incident but have been bereaved previously. And I know that you work with those children as well, and that you actually know who to target when you go into a school. So that is outstanding work, I have to say. I think then the question probably is, Chair, rather than what I was asking, is how does EA intend to mainstream this into our education system, because it is really, really important. We can't be hoping that lottery funding, it's really good and we're very lucky to have it.
Yeah.
But if we know it works and we know the impact that it's having, then we can't just hope that that lasts forever, because like all funding, it doesn't unless it's mainstream. So I think maybe that's the question we want to ask the Education Department, Chair.
And it's critical that all schools have access, and not just when they're actually impacted. The Northern Trust have set up a working group for compassionate schools, but the challenge for everybody is resource, because it is resource needing to go in, and we're a regional service, so we're to deliver right across Northern Ireland, so we've got a limited resource that we can put in, so we are responding more to whenever there's crisis. We've got an ambassador programme for children and young people now as well, which we're piloting at the moment within schools, where we actually help the school to have their policy, and then upskill some of the young people to be actual ambassadors, bereavement ambassadors. So it'll be interesting to see how that works. The other thing that's happening is that we're working with parents to upskill them. So if the child has been bereaved, we will work first and foremost with the parents and the significant adults in their lives, because if they're upskilled, they're with the children the most. So if they can support the children first and foremost and understand how bereavement impacts a child or young person, that gives the young person more coping skills for going through. And then if we need to come in and provide one-to-one support, we can. So it's very much about upskilling people around the children and young people. Because death is a natural benefit, it's a natural part of life, and we do have to have those discussions. And what we see coming through our doors is people come to us for bereavement, but if it's been a long journey or it's been a challenging health towards end of life, they're not just dealing with the loss of the individual, they're dealing with the trauma of what they have witnessed within the health. If you think about COVID and the people who died within hospitals, I have never experienced such pain and grief for those families now. Some of them are 5 years on, and it's a completely different way of working with people. So that's where, for me, it has really spoken. We need to ensure that within the whole health, it's not just about the health professionals doing, the families need to be actively involved. DNRs is a critical thing, ensuring that that is discussed at an earlier stage and not moving the persons at a critical stage. So we need to be bringing right upstream the whole making the wills, because people come to us also, they've been financially impacted. People may have lost their homes, they've lost their income. All of those things has an impact on grief. So although the person dies, the cost of the health service continues because the stress and strain which they're under is significant. So we need to pull it right back and make sure that the palliative care that's being given is inclusive and that the critical conversations are happening. The community organisations that Sharon talked about, there's a role for them all to play there. We need to ensure that the care planning strategy is funded and moving forward, because it will make significant difference for the future of the healthcare system. But people have been impacted by the lack of palliative care being available for quite a few of the health conditions.
Thank you.
Thank you very much.
Okay, Danny.
Thank you, Chair.
Thank you, Chair. I just declare an interest. As a nurse, I delivered palliative care for quite a long time in hospital, general palliative care. I also worked in the bereavement team within one of the trusts, so I'm very aware of the benefits of palliative care and specifically more bereavement support. I have a couple of questions just around, and I was very interested when you were talking about the gaps in palliative care for specific communities, isolated older people in rural communities and homeless people. And I think the report mentions in prison as well.
Yeah.
Could you expand a bit more on those gaps?
Well, I'm working within the Western Trust, even though Compassionate Communities NI has a regional approach. And I suppose in rural Fermanagh, that's a real challenge. And I know Professor Max Watson has been presenting to the inquiry also, because he sees the level of need on the number of older people that are living on in their own in rural communities. They don't have the same access to services because they're home care nurses are having to travel greater distances to get from one person to the other. So you have within a rural community, for example, say, I know there's been a case in rural Fermanagh where they couldn't get a farmer to go into hospital to get treatment, whether it was chemo or radiotherapy, I can't remember which. And what it was at the end of the day was he didn't want to leave his farm because it was lambing season. So this is the whole thing of there's specific needs within specific communities, that we need to be able to be flexible to adjust to that. The homeless community, I have Compassionate Communities has delivered advanced care planning to the Belfast Inclusion Health Club hub, and also I've been into a number of the homeless charities, and a lot of it was actually to do to support the staff, the frontline staff, because they're seeing an increase in the number of older people that have been homeless and have had these lifestyles that, and they themselves are witnessing friends within supported living that are dying, and they're facing these very challenging conversations about mortality and maybe making amends with families. So there's a lot of that going on, and a lot more of it. And support staff need supported. And within, I haven't got enough, I've spoken with the homeless or the prisons community, and what they're reporting is that because their frail population happens maybe from the age 50, again, it's because of lifestyle choices and what have you. They're finding that the prison guards are finding that they're undertaking more of a nursing role because they're living with comorbidities, they're losing their mobility, so they're more dependent on the prison guards for support. And I suppose that's stretching their capacity as well then to do the other things. So a lot of it is coming down to capacity, but responding to specific communities and their needs.
No problem, thank you very much. Thelma, just to pick up on the question that Linda was asking just about bereavement, bereavement services, where does bereavement services fit in to the delivery of palliative care as a systems approach? Where would you see the families and carers being supported?
There needs to be support at every journey, at every stage of it. So prior, because there's the anticipatory grief, and that can be really debilitating for people as they go through the loss of their loved ones, and then that there's information for people at the point of bereavement, and then about 6 months after can be a good time for people to start really avail of more one-to-one support or group support. So it just depends on the needs of the individual. So currently, if people come through to us less than 6 months from the bereavement, we will encourage them to go to Understand Your Bereavement, which is a seminar which gives them understanding about the impact, what bereavement is, how it can impact, and how they can work through. And a lot of people will say, you know what, that's helped me understand, I'm not going mad. And then some people will come back maybe after 6 months looking more support, so it'd be around either peer support, so we have peer support groups happening, or it would be one-to-one support. And again, it depends what our contracts are across Northern Ireland. So we have contract with each of the health trusts, and they would vary. Some is very much one-to-one, some is one-to-one and group support. The Understand Your Bereavement, some is like a 3-step, where it's Understand Your Bereavement into peer support, and then one-to-one.
So because of the health service contracts, because of the trust contracts, you deliver different types of support in different trust areas?
So we one of those 3 models. Usually it's one-to-one, which is the higher tier stuff, but people do need it as well.
Can it only be accessed in certain trusts?
No, we're covered right across Northern Ireland. So we have 7 locations. So we are in Enniskillen Hospital, Omagh Hospital, and up in Foyle we've got premises in Bishop Street. We're in the Northern Trust, we've got a couple of venues there that we use, community venues, Bangor, Downpatrick, Belfast, and Newry and Moy.
Thank you. I'm very familiar with your work. Just as Linda said, constituency-wise, people have talked about how much you've helped them. So it is
demand is high, and we can't respond to the level of need that's common. And I think just the complexities, I suppose the concern I have is that we're starting to see the impact of people bereaved during the pandemic, and that's a completely different way of working. It's more group stuff, but again, it's not, we don't have the funding to deal with that need. And there's a form of palliative care that was used, but families weren't part of it, or they were part of it through a screen, so they were at end life. So there's a lot of complexities in there.
It was a completely different death than before.
It's the most painful work I've ever done.
I'm just thinking as well, Thelma's, representing Cruse, but also bereavement support is provided by, other professionals in trust, as you would know yourself. So whether that be nursing staff, specialist social workers. So again, I'm thinking of, there's quite a wee bit of pre-bereavement work, would go on with children, as you would know, maybe the loss of mum or dad or a grandparent or whatever, and you would start that pre-bereavement work with children and then carry that on for months potentially after the death of a loved one. So again, there probably just needs to be more joined up approach to it all.
Yeah, and Foyle Hospice has a Healing Hearts, which is a children's service as well, and they would go in, and again from that anticipatory grief and walk, hand-hold.
Foyle Hospice, isn't it?
Yes.
I think myself and Alan went up and met them, and it was a fantastic service.
Yeah.
It's really, really brilliant.
They prepare the parents as well as to how to break this news. And then they do it's a creative engagement and creating memory boxes and teddy bears out of clothes and stuff, and they're very precious, and they really anchor, I suppose, the grief in something very tangible.
I think if we can get death, dying and bereavement into the school curriculum, that will make a big change for the future. So we need to be doing that instead of always dealing with a crisis. If we can start investing now, but we need to get our palliative care services into a model that meets the needs of everybody, and it needs to be a geographical spread and not a BT lottery. there's really good palliative care being delivered, but as
Yeah.
Sharon said, not everybody's actually having access to it. And I have experienced myself over the last year the hit and miss of getting supports, especially for older people, and they're not even living rurally. Stroke, and then taking infections on of, and back and forth to hospitals at costly ambulances having to be called. Whereas if there was a support going into the home for people, it's been stabilised now. So we just need to think about that, the impact one for the family and the patient, but also the cost to the health service, the use of the ambulance service to bring somebody who in some ways probably could have been treated at home. So
Certainly that's something we hear again and again. So.
Yeah, and I think whenever we deliver palliative care and end-of-life care, you know, we can do it very well. You've involved specialist services, and the legacy is that the family have had a very good experience, if you can say that, you know, but yeah, they can have a good experience, but unfortunately at times it's not a good experience for everybody. And then, as Thelma has highlighted, then there's those repercussions, you know, further down the line for the family. If they haven't dealt with, you know, things haven't went well. So it's important to try and get it right.
Yes, indeed. Just going to move on now. Dan?
It's just a very brief question. I mean, it is... I've done some work with folk who are looking to try to get the issue of death, dying, bereavement within the school curriculum, so we try to help children understand sometimes very difficult home situations. In your experience, I mean, and I know every child's an individual and every situation's an individual, I accept that, but I mean, is this something that you need to do very quickly after? Is it something that you need to continue to do? The kind of support that you would offer?
So we would always say to parents to be open with the child and to use age-appropriate language, and to look at the different kind of resources that can be used, and to keep talking about the person. So after the person has died, because children will sometimes, I don't actually have a problem. It's the parents got me here. So parents sometimes will not always talk about the person who has died. So it's keeping that memory of the person alive is important, and telling them some days they will have good days and other days they won't. And also at the different ages, they will respond to the bereavement differently. So it's giving parents and main carers the basic information of working with children and young people. But it is individual, but we need to support them and ensure that they're allowed to talk or not talk about it. The bereavement strategy, they actually are looking at a charter for children and young people. Following our conference in September a year ago, Dr. Donnelly went away and said, look, we really do now have to get a bereavement charter for children. So she's been working with children and young people from across Northern Ireland to get that. And they had an event down in Dungannon in March looking at, well, what should be actually in the children's charter, and we had about 100 young people in the room from across Northern Ireland. And at the end of it, because we've got the saying, it's okay not to be okay, and one of the young people who has come through our service and initially would not have spoke to anybody, and now 2 years after the bereavement is at the front delivering, I said, can I just finish by saying it's also okay to be okay, because you will have your good days, and I think we need to remember that.
Yes.
So we do, but it's creating that environment the children know it's okay to talk about them and it's okay not to.
Yeah, it's incredibly difficult, sensitive subject. Thank you. I think that you've brought a new perspective to us today, which I think is really, really important, in that we consider what palliative care services look like in its totality, and not just about what the medical interventions are and so on, but that we look at that broader picture. So thank you. I mean, I'm also interested in how we get these services delivered equitably across Northern Ireland and equitably to all communities, and the stuff in your presentation around the different interest groups is also really, really important. So thank you.
Thank you.
Yes, we're speaking into the microphones, but just some of the members online are saying it's difficult to hear, but I think it's more a technical issue than news, but just if you can speak a wee bit louder into the microphones, I think that we're trying to sort out our other sound issues. Alan?
Thank you, Chair. I assume Alan as in Alan R.
Yes, sorry, Alan Robinson.
That's okay. Thanks, Chair. And thank you too for that presentation, ladies. It's of great interest. It just, whenever Danny was speaking there, and I suppose when Diane was speaking about the various interest groups, it sprung to mind, the growing group of foreign nationals we have within the province, and it reminded me of a case that I dealt with a year or two ago of a foreign national family that are riding these shores, and they'd fallen in hard times. Literally, they had no knowledge of what to do or where to go to, and they came to me, and I effectively had to, point them in countless directions in order to gain that help and open various doors for them. And I'm just wondering, given that growing cohort of foreign national group, how, given that they are very hard to reach, how are you reaching out to that particular group?
Okay. We currently have funding through the Executive Office for working with people where English isn't their first language. We're going into the 4th year. We changed the model last year to being more of a group model where we bring people together with interpreters to actually go through and make it cultural sensitive, because how people grieve in other cultures is also different. So we've been doing some of those group sessions within communities, and we're also using some of the fund to try and recruit volunteers from those communities where we can actually train them up so that they can deliver the supports for bereavement into the community. So it's a new piece of work that we're doing. So it's interesting to see just what the need is, and it's greater than I think we actually realise. So hopefully this approach will help us to build capacity, because we most certainly were not reaching people where English wasn't the first language until this pot of funding came through. So this year we will be recruiting a couple more volunteers from different communities. So we've identified, through the workshops we've done with organisations, we've identified the individual communities that we do need to be reaching into, because there's been sudden unexpected deaths, but then they've also got the loss of loved ones. They're getting the message from home that somebody has died, so it's how we create that support around them. So we're looking at working with communities to do that.
Yeah. Within the Northern Trust, we've had a few where again English wasn't their first language, and the district nurse is the palliative care key worker, so she was very much coordinating care, have contacted our service on a few occasions just to get different resources translated into their language. We do have a palliative and end-of-life care services booklet, so we got that translated, which was great. I suppose the only thing was it did take a bit of time. So that was the downside. So we try to respond, where needed. I know again within the Macmillan unit, both, nursing, chaplains, social work services, again have responded to need. So we're trying our best, and I think it's working out. It's working out okay so far.
We're also co-designing resources, like animations that sort of try and translate complex terminology. So we've done that over the last number of years. So we have a number of animations, but also face to camera with different professionals right across the sector, whether it is a GP, a district nurse, or a funeral director. And they're hosted on a regional website, and we're continually, adding to that and engaging with media and through social media.
Thank you. That's very helpful. It's just, I suppose, another added dimension to the other difficulties within palliative care that you've alluded to in your report here. Thank you. We appreciate that.
Thank you.
Ladies, thank you very much. Really appreciate that. I mean, this is a very important conversation and inquiry we're having, and your part today has been very important and useful to us. So thank you very much for coming before us.
Thank you
very much.
Thank you.
And the work that you do.
For your time.
Thank you. Members, so we are just literally going to go back, not in time, but back to the start of the agenda. So I'm just going to go back to number 2, Chair's business. So can I thank the families who attended our informal meeting on Tuesday with the committee regarding serious adverse incidents. So, I mean, we're obviously going to continue to liaise with those families over the coming months when considering work on the SAI framework, the Adult Protection Bill and the duty of candour. Can I ask members just to note correspondence received from one of the family members following the informal meeting, that's at table 8 of our table papers, and just ask if we're content as a committee to write to the Minister to encourage him to meet with those representative families just to hear their experiences. Okay, Danny?
Yep, very happy to support that. It was a really, really powerful session. I know for the members that were there, really, really emotional, and certainly, you know, it does suggest that there are a lot of problems with the current system, and certainly communication with families is a huge, huge part of it.
Yeah, well, that's what I took out of it too. Definitely the communication, keeping families updated and even directing families in the right direction. Okay, so also just there was a kind of an invite to members of the Health Committee and the Economy Committee the other day from the BMA just with regard to medical students and issues that they're having with regard to fees, access to student loans for certain years of their study, etc. So a lot of the issues were directed towards the economy and the student loan companies, but given that it was medical students, you know, in the conversations there was implications for getting students to do particular aspects of study, and then also because of the debt that they're in when they come out, a lot of them are choosing to go and work elsewhere to pay off the debt quicker. So I think it would be useful if we alerted our Minister to this particular issue and asked maybe that we write also to the I mean, I don't know, in terms of the protocol, we should probably write to our Minister to ask him if he will engage with the Economy Minister on this particular issue, because there were certainly separate issues where medical students aren't able to access the student loan, and that obviously has an implication as for them, specific to medical students. Go ahead, Dan.
Just that I have had a number of cases where students have completed a degree but cannot get further funding or help to complete that graduate degree and to continue in their studies. And in a time in health when we're actually really searching for people with specialisms, I think that we're missing something here, you know, in not trying to support some, because some of them just cannot go on any further. That's it. Yeah. But would, if they were able to progress, and I think maybe that's the element of it that I was thinking about.
I think maybe there's 2 or 3 things. I think maybe we should write to the department to see if they're aware of this, and maybe to gauge from them how big an impact they consider this. With regard to the workforce situations, but then also that we write to the Minister specifically to ask him to engage with his executive colleague to resolving the issue. Happy enough with that, Danny?
There's a few specific issues that come out of it. I think there was a disparity between Queen's and the University of Ulster, the ability of students to get a loan in one university but not in another. That did seem wrong. And the other issue highlighted was it in the 5th year, where their ability to get loans is significantly reduced at a time when some of their costs actually go up. So they find financial hardship in that time as well, which I think is different than the rest of the UK, which does seem a bit strange.
Yep.
Thank you.
Okay, and then the other thing, obviously, and why we kept this, obviously, is in the last 10 minutes the Minister has issued his written statement. So obviously, I think it's important to welcome that action is taken. It's very disappointing. Probably, I think there's a disappointment we all share that it's a written statement and not made before members in the Assembly. I mean, we'll all have read the statement. There's maybe a lack of detail in it. There certainly are questions that I think certainly members of this committee would have liked to have been able to ask the Minister in the Assembly for further detail and the implications of it. But certainly, I mean, primarily, we know the issues within the Belfast Trust. Those issues are affecting public confidence. The public do need reassured, and we need to be satisfied from our point of view as a scrutinising health committee that we're doing all that we can to ensure that the public are reassured and that this work is ongoing. So, subject to that, we had confirmed that the Belfast Trust are coming to the committee next week. I am also going to suggest, members, if you agree, that we invite departmental officials here as well, so that we can explore in detail further just exactly what this rise to special measures or level 5 means, and that we hear from them. There are, as I say, a certain amount of disappointment that we won't be able to question the Minister and the Assembly on it. So I think that we should be inviting departmental officials at the very least next week, where we can engage with them but before the Belfast Trust as well, so we have a full explanation. And then, further to that, again, we have had confirmation just in advance of the committee meeting that members will receive the report, because obviously that is crucial. I mean, that has been a complaint a lot of members have been making in the last week, that a lot of this has been discussed through the media and we haven't actually seen the details. So it's difficult for us as a scrutiny committee to know the true extent of the problem, but more importantly to scrutinise the recommendations and the action plan. Of the most important aspect is how the Belfast Trust are going to turn this around. But as I say, we have been made aware that we as members will get sight of the committee report potentially this afternoon, but by tomorrow. So the clerk will give us further details on that moving forward. So I'm just hoping that people agree that we do invite the trust officials next week.
Absolutely.
Yep. Okay. Colin, you had your hand up there. Do you want to come in on this?
Yeah, thank you very much, Chair. And just apologies, my internet's just a wee bit unstable. It's saying there, so if I get cut off, apologies for that. I want to commend yourself for holding this item on until after the 2:30. I'm not generally a cynical person, and I'm sure people like Diane will hold her smile back there. But I think to actually have this embargo to 2:30 on the day that we have a committee was a cynical attempt to try and prevent us from discussing us under the opening parts of this agenda. This is an incredibly important matter that needs to be addressed, and the statement does raise a number of questions rather than providing all the answers. But I have to say, I'm bitterly disappointed with the Minister if that was his approach. It was a written statement instead of to the House, and it was trying to embargo it so that it would go past Chairman's remarks at this committee. And I just think that's an atrocious way to treat the public who have got concerns about these issues that they've raised with all members of the Health Committee. There are a number of people from a number of trusts that are contacting me about issues. This is much wider than one service in the Belfast Trust, and I think that it's incumbent upon the Minister to start fessing up and answering the questions that we have rather than trying to hide behind process.
Yeah.
Yes, thank you, Chair. And again, like Colin, thank you for holding this at a time when we could discuss it openly and in public, and I suppose thwarting the Minister's maybe cunning plan. I do think, I welcome this. I welcome intervention in the Belfast Trust. I've been calling for intervention for a very long time now, and I think it's beyond time that we actually had measures. And I hope that the measures that he's talking about are trust-wide, and that they are about the accountability of the whole trust, including management. It's not just good enough to give us a flurry of activity in the last week, because we've had years of inaction within the trust and actually nothing done about these things. And it's allowed this really toxic atmosphere to develop. And it's not good for staff. Staff deserve better than that. And it certainly doesn't instill confidence in the trust. So I hope it is a whole trust approach. And that we're looking at management and not just one particular directorate within or unit within the trust. Can I say as well, I hope that the Minister, when he receives the trust action plan, will lay that before the House and come to the House and tell us how he is going to hold the Trust to account and implement the action plan. We need to see the extent of the action plan. We need to see whether it covers all of the issues. And I hope that the Minister will come to actually do that in the House. It's an important part of the scrutiny of this place, and that is extremely important. I note as well that he is recommending interventions from some specialists in the area, and he's talking about appointing a team to look at this and would look at this, an external expert with a departmental accountability team. I'd really like to know what that means. I think that's really important. We'd really like to know what that means. And of course, Peter McBride is a well-recognised professional who has already done a report into this toxic environment within the Belfast Trust. So I do welcome it, but it's scant on detail and understanding of how this will be implemented. And the Minister does need to come when he gets that action plan and to tell us how that'll be implemented and how widespread it's going to be.
I mean, you've raised the questions that I think all of us will have thought of when we were reading this report,
Yes.
and that's why it would have been really ideal to have had the Minister
Yes.
in the Assembly where we can actually ask him the questions. I mean, I'm reading the report and it's saying, or the Minister's statement, that the Department's performance accountability process for Belfast Trust has been raised to level 5. So for that, you assume that it's for the whole trust areas, but then there's other aspects of his statement which are very specific about the cardiac surgery unit. So we just do need to get that kind of detail, which, as I say, I think that it's important that we have at least officials here next week where we can ask them all of these questions and just have a bit more detail so that we can perform the duty that we're supposed to do for the public.
Thank you. Yeah.
Okay, Danny.
Thank you, Chair. Chair, can I just associate myself with the comments Colin and Diane had made just about the embargo until 2:30? I think that's ridiculous. I think there did seem to be some sort of a plan here to prevent this being discussed at Health Committee.
Yeah.
I don't really understand why there would be an embargo until 2:30 on a day of Health Committee otherwise. So I do think that's a bizarre situation. And again, yeah, I think we did need the oral statement and the opportunity to question the Minister. So having a written statement with a lot of vague detail isn't great, but the opportunity to question the Trust next week should be.
Yeah.
Give us more
And
answers.
it's obviously, I mean, the statement was embargoed to 2:30, and I mean, I listened to Colin down on the news this morning. So I mean, the media were obviously briefed that the statement was coming and briefed about the detail of the statement. It just makes a mockery of us as MLAs when the department are briefing yesterday or this morning about the detail of a statement, and we're receiving it in written form and it's embargoed to 2:30, and we can't question in the Assembly chamber. We are an important function of scrutiny on behalf of the public, and we just need to make sure that we don't let people away with that when we need to hold them to account moving forward. Okay, so just moving on then, members. So item number 3 is the draft minutes. So draft minutes of meeting held on 29th of May. Everybody content on the minutes? Yes. Matters arising? None. Okay, we've had item number 5. So we're just going to move then to item number 6 on our agenda, which is oral briefing from the Royal College of Paediatrics and Child Health. So can I refer members to the 2024 report, Worried and Waiting, and that's at page 39 of our papers. So just wait till they come in. Can I welcome to our committee Dr. Thomas Bourke, Officer for Ireland, Dr. Rory Sweeney, Deputy Officer for Ireland, Dr. Julie Ann Maney, Joint NA Representative on the RCPCH Mental Health Advisory Group, and also Anna McDaid, Head of Policy and Public Affairs for the Devolved Nation. So you're all very welcome, and you have 45 minutes, or we have 45 minutes collectively for this, so I'm going to hand over for some opening remarks, and then we'll take questions. So hopefully you've agreed who's going to speak.
Thank you, Chair, and committee members for welcoming us and inviting us to speak this afternoon. Dr. Julianne Maney, Dr. Rory Sweeney, I'm Dr. Tom Bourke. We're paediatricians, and Mrs. Anna McDaid is a senior policy advisor. And we're here representing the Royal College of Pediatrics and Child Health. Our college has 25,000 members in the UK, with 450 members here in Northern Ireland, about 100 members in the Republic of Ireland, and many other members across the world. And one of our main roles is to advocate for the health and well-being needs of all children and young people. We understand the pressures there are across the health and social care system. However, as frontline children's doctors, it often feels like children's services are not prioritised, and in fact sometimes we feel we're actually being ignored. Waiting times in Northern Ireland are out of control. They're 3 times higher than in Scotland, and they're getting worse. We're very grateful to the committee for giving us this opportunity to highlight the impact that delays in emergency, outpatient, inpatient and community care are having on the health and the well-being of our children. The main issue we want to highlight to you today is the dire situation with the waiting lists, but we will also highlight some of the broader issues with child health services. In April 2024, we published our report Worried and Waiting, a review of paediatric waiting times in Northern Ireland, and thank you to Mr McGrath and Mr Donnelly for sponsoring that report. When we published that, there were 22,000 children on waiting lists. This was up from 8,000 in 2016, a 170% increase over that period of time, with an upward trajectory that was there even before the pandemic. Even more worrying, 6,000 of those children, 28%, had waited longer than a year. And this was up massively from 2016, where it was only 7% of the children were waiting that long. One of the huge challenges we have with this data is that it's not broken down by specialty, and that makes it difficult to fully appreciate the complexity of the situation. The introduction of Encompass is a good thing, and we're confident that moving forward we will be able to break this data down more so that we can further understand the complexity to help us all plan for how best to use our limited resources. Unfortunately, though, the introduction of Encompass means that we cannot compare our data from the last year to our report in April 2024. Having said that, it is our experience as frontline clinicians that the waiting lists continue to grow. And the data that we do have from the Belfast Trust and South Eastern Trust, where Encompass was introduced first, does show that waiting lists are continuing to grow for children by about 6% per year. So based on our experience and the data we do have, we have no doubt that there are still well more than 20,000 children and young people on waiting lists for paediatric medical and specialty services, and that many thousands of those children have waited longer than a year. If a 4-year-old waits 2 years to see an allergy specialist, that's half of their life. And yet we know in allergy that early intervention can reduce their lifelong symptoms. These delays are leaving children and families in discomfort, pain and distress. The evidence is strong that failure to manage conditions well in childhood is clearly linked to chronic disease in adult life. They're missing school, their family lives are disrupted, and their social development is impacted. Ultimately, the trajectory for their life course, their employment, their well-being, their mental health, and ultimately the economy of Northern Ireland is affected by these issues. I'm sure we all agree these numbers are shocking, unsustainable, and they're unacceptable to our patients, to your constituents, and to their families. Our paediatric inpatient services continue to run at almost full capacity, and that impacts on our ability to manage elective admissions. These figures are very hard to capture, but as an example, in March this year, there are 800 children waiting for an ENT procedure. Now, those children have already come through that outpatient waiting list that I've already talked about. They may have waited several years to see the consultant, who then has made a decision that they need a procedure, and they go on to the next waiting list. 140 of those children have been waiting longer than 2 years. These children are getting recurrent ear and throat infections. They're at risk of hearing loss. They're missing school. They're attending their GP, and they're attending our emergency departments, and they're requiring frequent antibiotic administration. And that's just one example from one surgical specialty. You're all well aware of the challenges facing our emergency departments, and they're in the news every week. But another example of one of our frustrations is that emergency care official statistics don't focus on children in any meaningful way, offering further evidence that children's services are overlooked and deprioritised. For example, the review that informed the Regional Urgent and Emergency Care Plan identified under 5s as frequent users of emergency departments, and yet they weren't mentioned at all in the ultimate strategy. Again, we need to understand these data better and ensure that children are not only included but are actually prioritised in any emergency care long-term strategies and implementation plans. In 3 weeks' time, we're delighted to come back to the Assembly, where we'll be launching another report, this time focusing on waiting times for community paediatric services. And again, we're grateful to Mr McGrath and Mr Robinson, who are facilitating this for us. I know many people on this committee are interested in the diagnosis of autism and ADHD, and this is one of the primary roles of our community paediatric colleagues. They also look after the most complex children with cerebral palsy and severe neurological disease, and they're really, really good at keeping these children at home and out of the hospital. Without delving too far into the specifics in advance of our report, we have found another genuinely worrying situation. There are at least 10,000 children waiting for a consultant appointment, and something like 35,000 children waiting to see the allied health professionals, the physiotherapists, speech therapists, dietitians, and occupational therapists. Again, you all know the impact a delayed diagnosis of ADHD or autism has on a child's education, their well-being, and ultimately their path in life. From this report, we will be recommending bespoke networks of clinicians and a regional action plan based on good data and quality modelling, and we hope the committee will take into consideration our in-depth report when we share it with you in a couple of weeks' time. Finally, I'm going to highlight children's, adolescent and mental health services and the prevalence of poor mental health, which again I know is a topic that many of you are passionate about. Dr. Maney and her team in the emergency department meet young people every single night who are in crisis. They're often the most distressing cases that we look after, and they're only in the emergency department because they have nowhere else to turn. 1 in 8 of our young people experiences mental health problems like anxiety and depression, and our levels are 25% higher than the rest of the UK. CAMS waiting times again are high and getting higher, with over 2,000 children waiting for assessment in Northern Ireland. If we do not invest in services, these children continue to be passed from pillar to post, presenting to already stretched primary care and emergency departments, and then ultimately joining the adult waiting lists, which again, as we know, are under extreme pressure. I would like to thank the committee for their time and just sum up with a few more comments. There are lots of areas of good practice across Northern Ireland. There's the Belfast Trust online symptom checker, which has the potential to reduce ED and GP attendances. but we would call for full funding and implementation of the Healthier Together, which is a much broader online platform that allows us to develop robust pathways and to communicate much better with our GP colleagues, really with an aim to keeping children out of secondary care services. We have an NI peer group which is developing guidelines for district general hospitals, and that ensures that we're all practicing uniformly. There are GP hubs in the Southern Trust, which again have really robust data to show that they're keeping children out of secondary care, and we're developing educational collaborations with the GP federations and GP NI with the same aims. All of these initiatives are great and they are successful at a local level, but they need to be properly resourced and rolled out across the country as part of a wider strategic plan. As I know you are, we are all delighted that work has started on a new children's hospital for Northern Ireland. I don't know if any of you have been on site, but it's fascinating to see the cranes and the diggers and the lorries in there. It's really exciting to see things moving on in a tangible way. But it is only a building, and it will not solve any of the problems we've highlighted today without significant strategic reforms across the nation. So we, as frontline doctors, and on behalf of the Royal College of Paediatrics and Child Health, we're asking you as a committee to highlight the dire situation our children are facing, with over 20,000 on medical and specialty waiting lists, with many of those children waiting more than a year. To highlight the unacceptable waiting lists for ADHD and autism diagnosis, which is significantly impacting on the learning of children. And just to be aware that our Children's Emergency Department and our inpatient services remain under significant pressure. More importantly, we're asking you as a committee that when you're scrutinising future policy and implementation plans, that you look to see that children and families and paediatric services are not just considered, but actually that they're being prioritised in those reports. We would be grateful if you would consider calling for a detailed review of child health services and of the whole child health workforce across the nation, again, so that we can clearly understand these issues and plan for the future. We would call for the Child Health Partnership to have sufficient resources to drive the sort of strategic reforms that we feel are required. And finally, we're calling for the implementation of a child death overview panel, which Dr. Maney will talk to you in a moment. So thank you, Chair, for the opportunity.
Thank you. And you said we should be shocked at the length of the waiting list and the numbers on it. I've just found myself being shocked nearly on a daily basis at the minute. I'm probably more depressed at this stage than shocked, because those figures are deeply depressing, to be truthful. I mean, 172% increase, in 7 years. I think that's extremely depressing and something that we really need to turn in a different direction. So we all welcome the building of the start of the building in the Children's Hospital, but you quite rightly said that it's only a building. We need service. So in terms of the structure and governance reforms, that need to urgently happen, what specifically are we talking about?
There is some progress with the Northern Ireland Child Health Partnership. They now have a director as part of the group, and they have direct accountability to the permanent secretary, but they are still significantly under-resourced. And they struggle, like we do, with the complexity of the data and the complexity of child health services as they are in Northern Ireland. We present to you the waiting list data because we can get that data from the systems that are already there, but they're only a marker for the challenges that are out there. But the problem is we need a review of child health services as a whole to really understand them. We have loads of anecdotal evidence across lots of different specialties, but we need that review so that we can be specific about where the change is needed. And that would need to be strategic change about how we develop and deliver services across Northern Ireland.
That's very clear. You mean, we talked about the hospital, Children's Hospital in the north, but there's another, the Children's Hospital in the south, although beset by problems, is hopefully going to open in June 26. Is that something that will benefit, will we be able to benefit from in terms of reducing some of the waiting lists, or how do you see the interaction there?
Sweeney has been down to the Children's Hospital in Ireland?
Yeah, I didn't do the site visit at that time, but I worked down in the older Children's Hospital, kind of doing a paediatric transport fellowship with them, so have an insight into a little bit of how the system works down there, but also how we're already engaging, I suppose, with services in the south with the All-Ireland Congenital Heart Disease Network, which has been established now for a number of years and has been a very successful model, but is sort of coming up to having some difficulties with how it's going to expand in the future. So the way that it works at the minute is obviously the services in terms of the surgery are centralised in Dublin, but we have waiting lists for outpatient clinics and cardiac non-surgical services which still happen in Belfast. Mm-hmm. So it means people can access services closer to home, get their investigations, get their outpatient reviews closer to home, and then travel down to Dublin to have their surgeries. Some of the post-operative care will happen in Dublin, and then they will travel back up to Belfast again for sort of ongoing care and review. So that's quite a useful kind of hub and spoke model that might be able to be applied to other very specialised services, which could have some impact on waiting times. The other aspect of it is that it's being used as a training model. So the way that paediatric cardiology training had always worked was that you had to go through a very unusual pathway compared to the rest of us paediatricians, where you joined the adult Royal College of Physicians, got trained through the Royal College of Physicians, and then specialised in paediatric cardiology. So it was a bit of a strange path to access. But as part of the All-Ireland network, they developed a training pathway for the whole island of Ireland. So trainees from the south and the north work together on the same training pathway, do some of their training in Dublin, some of their training in Belfast, and everybody moves around the different systems to get the full experience of what's happening on the island of Ireland across the different networks. However, the training is not being recognised at the minute between the IMC, so the Irish Medical Council and the General Medical Council of the UK. So we have currently a number of trainees who are just about to finish that programme who will be unable to take jobs as paediatric cardiologists in Belfast to support the services in Belfast, because there's no recognition of this training programme that everybody on the island of Ireland has taken such pains to establish. It's really key, because this model, paediatrics, is a relatively small specialty, and especially once you get down to the sharp end of specific rare diseases. So being able to access the population of the whole island to train specialists is a very, very valuable tool for us going forward to support our workforce in the future and to support these services in the future. So if we got it right for the cardiology services, which are very well established, and we got joint recognition of these training programs, it would be a very useful way for us to train across different specialties. And as I say, I did do some of my training in Dublin, but it wasn't in an area that required a very specialist sign-off to allow me to practice that. So the transport services are recognised. Things like cardiology, neurology, metabolic, inherited metabolic diseases. These are things, gastroenterology, have very specific specialty training pathways which are recognised through the Royal College of Paediatrics and Child Health and the GMC, and you can only be signed off as that very specific level of consultant if you've gone through their pathway. But we're sort of in a uniquely difficult position in Ireland, where that would mean people have to travel away from families for a number of years to other parts of the UK to get those signed off, whereas we actually have access to something that feels like it should work. Cardiology have taken a lot of effort to try and make these things happen, and we could generate a lot of new consultants to support the workforce and therefore impact on your waiting lists, as your question alluded to at the start. So we've got both things, might be accessing some of the services from the Children's Hospital itself, but actually using it as a way to bolster our training and bolster our workforce. Not only is there a difficulty with the Irish Medical Council and the General Medical Council, but from a purely transporting point of view, we've tried to, you may be aware that paediatric transport services have had a lot of difficulty with recruitment and staffing, and in order to try and produce a service that is able to move patients around Northern Ireland to access paediatric intensive care services, but also to move patients between Belfast and Dublin for their congenital heart disease services, we have implemented training for advanced nurse practitioners, and we have a couple of guys who finished their programme, but again their training in Belfast is not being recognised in Dublin, and currently they're unable to perform their role of transferring children from Belfast to Dublin, because once they cross the border they're no longer recognised prescribers, they're no longer recognised nurse practitioners, they just can only be registered as nurses currently, which means they can't do all the things that we train them to do to support the transport services. So we've got a real issue of kind of cross-border agreement for what comprises appropriate training, and it is having a real impact on our ability to be able to access these services which are out there.
That's disappointing to hear, I have to say, and something I think we should probably look into. In terms of the Minister has announced 215 million for reducing waiting lists. Has there been any engagement with the department with regard to how some of our, whatever percentage of that money will be spent with regard to paediatric waiting lists?
I was very pleased to see in the Minister's announcement specific provision for children who need PEG tubes, for children who need scoliosis surgery, and for endoscopies. For children who need those surgeries, it's life-changing. Again, we're seeing children in the emergency department where their tubes have come out, where they're aspirating. It can be really distressing, and it can really impact on their lives. But it is a small number of the children who are on these waiting lists. So yeah, we would be calling for any waiting list initiative going forward that it would have specific mention of these paediatric medical specialty waiting lists that we've emphasised there in our Worried and Waiting report. And waiting list initiatives are part of the solution, but we've had them before and they worked, but they need to be in parallel to strategic long-term investment in our workforce and in our infrastructure, so that we don't get into a cycle of bust and boom.
And we know what parents want. You know, we understand the system. We know what parents and children and young people want. They want timely, access to services. They want to be seen by the right people at the right time in the right place. They don't mind travelling for a regionalised service, which paediatrics lends itself to really well. They're also happy to be seen in spoken hub models with specialist input. We already work really closely with our primary care colleagues in GP services. We work together. We try to, make safer plans, how to work better together within the system and the constraints in which we work. We know there's no money in the system, but actually the way the system is set up and the way the system is designed could be much better for children. There's a lot of services that are good, but actually they'd be better served the children of the population. We're public servants. We work for the public. We work for the children that we look after. The service is designed currently for the people that work in the service rather than the people that use the service, which is not the way it should be. I work in the emergency department in the Royal Belfast Hospital for Sick Children, and I know some of you have come and seen our department and seen how we work, and it's very small, it's not designed, it's not fit for purpose currently. We are moving to a children's hospital. I was involved in those plans 20 years ago. They're still, we're still not in the children's hospital, but as Tom says, it's a building. The people that work in paediatrics, we're like the toddlers of the health service. We want to make things better. We are active, we're interested, we're enthusiastic. We know the solutions, we have the solutions. We just need you as our political representatives to listen to us and make those solutions workable for us. Our frustration is we know what to do, we know how to do it. We just can't get to the decision makers, people like yourselves, to make those things happen. It's really frustrating for us because we are problem solvers, we're pragmatists, we know exactly what to do. It's just getting the impetus, and you know, we're often a Cinderella service in paediatrics. You know, it's a secondary thought. So, for example, our trauma network in Northern Ireland is specifically designed for adults. The Royal Victoria Hospital has a major trauma network, so by default, the Children's Hospital has now a trauma network, but we're not funded, we're not resourced for that. And children should be coming to a major trauma centre in Belfast, but my colleagues and I are crying out for funding, but the commissioning is not there. There's no money to fund this service. We have to be invited by our commissioners to say what we need, how we need it. We know exactly what we need, but it's very difficult for us to find a voice for the children that we look after. You know, 500,000 children are in Northern Ireland, but they're not being served by, you know, the health service that currently is set up. The other thing I wanted to bring up was the child death overview panel, which is a really important. So if you look at the number of deaths in children, it's sort of a highlight to the deficiencies in the health service. We have 180 children die every year roughly in Northern Ireland, and there's no sort of overarching body that's looking at the learning from child deaths, preventing child deaths, and also the support of families who are bereaved, which is really, really important because it's life-changing when you lose a child. It affects your whole life, the whole community. You know, I know on Monday, Caitlin Rose McMullen's mother came to Stormont to highlight the deficiencies in bus safety. We've been highlighting those concerns for years and years and years. And it's really important that we do, but there needs to be a mechanism that has statutory and legal powers to change the way society is set up for children. So, you know, 20-mile-per-hour speed limits, that if a child drowns in the Braid River on Monday, that we can change the legislation, that a fence goes up to prevent that death from happening again. You know, is there sepsis alerts? Is there things that we can do to prevent children from dying? The way society is set up, that they don't come to us when they step off a bus and get knocked down. You know, there are things that we can do, but that needs investment. It needs people to do it. And, you know, the outworkings of that will be a healthier, happier society for children.
Thank you. Impassioned, but very, very important. Diane?
Thank you. Just a few brief questions from me, and I apologise. I know I was talking to you before this session that I have to leave. I too have been looking at waiting lists for our children in Northern Ireland, and the figures I got up to December 24 indicate that in the Belfast and South Eastern Trust at least 25,000 children are on a waiting list to see a paediatrician, and another 2,000 are on a waiting list for paediatric surgery. The median waiting time will in the South Eastern Trust is 48 weeks, and that can rise to 190 weeks for those who are on the 95th percentile. So it's pretty terrible stuff, and that is only 2 of the trusts in Northern Ireland. And I must say I had seen your report earlier last year, and I was shocked that that continues to rise. So in preparation for today, I kind of looked up the elective care framework and the plans for how to spend 215 million. Now, I could be wrong about this, so bear with me. But I could only see 2 million for ENT and 3 million for that range of specialist procedures that you talked about, PEGs and scopes, out of 215 million. Am I right?
Yes.
Yes, yeah, that's our understanding, yeah.
So that is, I'm going to say this again, so that is 5 million out of 215 million specifically targeted at children, yet we have waiting lists like that.
Yes.
So I just want to make that point and clarify that I am correct in saying that. And that's I think that just speaks for itself. I genuinely do. and the priority that that update to the elective care framework gives to children on our waiting list. And I actually think that's maybe something, Chair, if you want to consider that we actually write to the Minister about, because I do think that is significant. I suppose there's two other questions that come to my mind when I'm thinking about this. And one was that transfer age of children from children to adult services. And I've had much contact with parents who find that an incredibly difficult experience, often with young people who are life limited, who may not fully understand what is happening, and parents who've grown up with the children's services and all of a sudden find themselves in the different world of adult services. So maybe just a very brief comment on that, because I do think that we could do a lot better in relation to that. I do think that is really significant. And the other one is around children with requiring PEG surgeries. Now, we've had some, you know, that we've had a lot of representation here from parents who are very, very concerned about children requiring PEG surgery in the waiting list. Now, thankfully, that waiting list has gone down, but it has taken interventions not from here. Am I right in saying that we do not have a paediatric gastroenterologist in Northern Ireland that has that tertiary level qualification in the subject, in that area of experience? Am I right in that?
Not. We'll start with the last point first. We agree that PEG issues are huge issues for those families.
Yes.
And again, as the generalists and the emergency department and Rory in intensive care, we see the complications for these children when they don't get the right care, and we welcome all of the investment that comes with it. The gastroenterology situation is complex and evolving, but there are gastroenterologists in post. And there is a reasonably consistent locum cover for the other gap. But PEGs are delivered by the paediatric surgeons at the moment, which is maybe where that little bit of information or clarity maybe is needed. So our gastroenterologists are in post, but they're not putting in the PEGs. The surgeons are putting them in.
No, I understand
and they're under
that,
the pressure.
but
Maybe that's where that's coming from.
And are they gastroenterologists that specialise in this? Yes, they are. So that I know, it's a question I've been asked. That's why I'm asking.
So the paediatric gastroenterologists would look after children with sort of gastrointestinal issues. They also look after children who have PEGs. They would also ask our paediatric surgeons to insert PEGs for certain gastroenterological conditions. So yes, there is a service. It's not as robust as we'd like it to be in terms of gastroenterology. Our paediatric surgeons would generally put in the gastrostomy tubes, and as an emergency clinician we see children who don't have the PEG tube inserted, who need it. So they're coming in the nasogastric tube, which goes from your nose to your stomach, the nasojejunal tube, which goes from your nose to your jejunum and part of your small bowel. You know, they come out, they get dislodged. It's very distressing for families. They have to come up to us. You know, we have to repeatedly x-ray them, so the more radiation you have as a child, the more likely you are to have cancer as an adult. So, you know, there's long-term effects of a poor service for these children. And, you know, our paediatric surgeons work extremely hard. They work on 24-week infants who are 500 grams right up until, you know, the 14th birthday. So, you know, it's difficult for them to provide such a service, but again, it needs to be commissioned, it needs to be funded, and there needs to be some level of sort of oversight for all of this. But, you know, in terms of our gastroenterology service, yes, you know, it's there, but it could be more robust.
It certainly has improved in recent months.
And that transition period.
That's a huge problem. As you're highlighting, as your constituents are highlighting to you. It's a huge problem. There's different domains of transition. So there's children who have conditions for which there is a service, maybe epilepsy or Crohn's disease. And even those children, we cannot refer them until they're 16. And then they go on to the adult waiting list. And they may be well into their 20s before they're picked up by the adult service. But at least there's a service to refer them to. Even more difficult are the children you're talking about with complex neurodevelopmental problems that are looked after by those community paediatricians I mentioned really, really well. And there is just nowhere for them to refer them to. It is a huge gap for
what
these
actually
young people.
happens to because
They go back to their general practitioner. And again, we all know how under-resourced our general practitioner colleagues are. They have to present to the adult emergency departments and wait and spend time in trolleys waiting for inpatient care.
But as paediatricians and the Royal College of Paediatrics and Child Health, we advocate for age-appropriate care. It doesn't really matter to us how old children are. You know, it doesn't really matter. So, you know, we would see...
It doesn't matter if you're 16 or 18
So we would see a
20,
20-year-old or a 17-year-old. And, you know, in the Children's Hospital, in the emergency department, we would never turn anybody away, even if they're 17, 18, 19, 20. Last week we saw a 21-year-old because they're not quite transitioned, because the adult services are just not there yet. We're working very hard with our adult colleagues to take on sort of adolescent transition population, but for children with life-limited conditions who have had holistic care from a community paediatrician who they can lift the phone to, from specialist nurses, that sort of level of care isn't quite yet developed in the adult world, and they're frightened. They're frightened to go to the adult emergency departments because they are a frightening place, they're a scary place. They know when they come to us, they go, oh, hello, how are you? Well, how is he today? How is she today? What can I do for you now? Tell me what you need, tell me what you want. And that sort of level of sort of intimate relationships that we have with families just doesn't quite exist in the adult world yet. Now, we're working very hard to make that happen. And again, we have lots of, you know, very keen, interested adult colleagues, but again, the services are just not quite as developed. And we always defer back to our general practitioners who, as you can appreciate, are under huge amount of pressures, but again are very, very good to their patients. And I think that, you know, the children with the life-limited conditions is a testament to how well they've been looked after, you know, in, you know, the perinatal units, the special care baby units. You know,
yes, because I've spoken to parents who are devastated that
frightened.
they have to move, and they're really, really frightened. And they don't understand what's the next thing for their child. Thank you very much, and I apologise that I have to go.
Thank you for staying.
Thank
We
you.
really appreciate it.
Really
We really do value your time. Yeah.
There's a significant body of work that Scottish Government and Healthcare Improvement Scotland have undertaken in terms of transitions. It's been around an 18-month programme that's been led from beginning to end to map out all the services to make sure that there's commensurate services and those children transition smoothly in Scotland. A lot of that is encompassed around the understanding that they now have ENC incorporated, and those children's rights are much more protected than they were before. But it's something that this jurisdiction may want to look to in terms of understanding that body of work, and it's something that we're always content to support with, because we have members across Scotland that are always willing to support other devolved nations.
Thank you very much. I think this is something that we will return to, because personally, I personally think it's a really, really huge issue for a group of parents who have come through a tough time and need support, and suddenly it's not there.
They need holistic care. They need someone
Yes.
that knows every single thing about their child, and that's really important.
There's a huge regional variation as well. So in different,
Oh, now that
as there always is, different
There always
different
is.
specialties, different parts of the country have age cut-offs at different ranges. So people are half transitioned in one place and not in another
I
place.
don't
and it's
think
very,
we
very
ever get
difficult,
through
you
a
know.
health committee without saying that.
Health committee bingo.
Well, we're going to have to keep moving on because
Thank you
we've
very
a number of other members. Linda.
Hi, how are you? Thank you very much for the presentation. Really appreciate it. I think you said about being surprised at some of this. Unfortunately, not surprised. Devastated is probably a better word than surprised, because all of my worst fears have been confirmed by you here today. In terms of the families that are coming to me, particularly around those very specific and life-changing, and in some cases life-limiting, and quite a number of cases life-limiting conditions. And we're talking about the waiting lists here for the services that are there, but the people I'm talking to their child is not on any waiting list because the services are not there. So I suppose my question to you is around, you've talked about the hub and spoke. I'm really, really concerned about that stuff around the north-south, because I was very hopeful that there could have been more work, not only north-south, but right across these islands, because I know whenever it's specialist services for specific conditions, you can only be a specialist if you're seeing enough people with the condition. So that's really complicated. So I was hopeful that there could have been more work done in that space right across the islands, with all of our health services working together and doing more of that hub and spoke work, where you may have a child who has to travel to England for surgery or to Dublin for surgery, but can have their follow-up in Belfast, or, you know, follow up at home here on the island if they have to have their surgery in England. So I was really hopeful that there could be some more work around that. So just to get a sense of, are there solutions? Can we have some more work around that? And then just in terms of, I'm thinking specifically for young people with like Duchenne muscular dystrophy, there is no counselling service. No specialist counselling service currently exists for those children. Those children have life-limiting health condition. When they're reaching, they're all young boys, obviously, because it only affects young boys. But when they're reaching their kind of, from probably about 8 or 9, when they start to understand their condition, they absolutely need counselling, and there is no specialist counselling service for those children. So I suppose it's to get a sense of, you know, I suppose one thing that does give me hope is yourselves, that you do seem very keen. Yet you're saying that you have the solution. So it's to get a sense from you about what are those solutions, and we are your listening ear today. If we know what the solutions are, then we can fight with the Minister for them. We can't deliver them. No point in telling you lies. We're the Health Committee. We're here to hold the Minister to account, but we can absolutely hold the Minister to account and the Department to account on how to do better for our children and how to do better for you who are trying to deliver the services for the children.
Thanks. I'll start with the counselling point, and maybe Rory will talk about north-south again. It's very important for those children with Duchenne's and many, many other children with chronic diseases. And that's why we talk about the child health workforce as a very, very broad term. This is not about more paediatricians or children's nurses. We need all of the other allied health professionals. So one of the things we did ask for or call for in a word and waiting review was a review of all child health services. So it is my experience in most clinics that I have a child who would benefit from seeing a psychologist. And I have to tell those parents that the waiting list is more than a year at least for those services. So we need psychologists and dietitians and speech therapists and all. And that's where what we're asking for is a review of the whole child health workforce, so we can identify exactly what those gaps are, so we can come back to you guys in the Health Committee and in the commissioners and say this is exactly the number and type of professionals that we need. Rory, north, south?
Yeah, so as we mentioned earlier, there is a fairly very well established network for congenital heart disease, which is just coming across a few very specific barriers to do with the training bodies and sort of recognition of training in terms of ruling that out. And I think trying to get a solution to those issues, and the cardiologists have presented letters to the Minister and have sent out very specific requests about what would be needed between the two bodies to recognise training. If something like that is able to be put in place for cardiology, it sets a very good precedence which we can then use for other paediatric services. So we were talking about gastroenterology earlier, and currently one of the gastroenterologists working in the Belfast Trust at the moment did her training in Dublin, and is able to work there despite not having a completely recognised, signed off special interest, because she's done all the equivalency training. So she's kind of had to forge her own pathway, and there's currently another paediatric trainee down there at the moment doing the same thing to try and support the services. This is people sort of taking a risk and going off themselves rather than doing something in a supported way. So having some official input from the governments, both north and south, to say that training will be recognised across different jurisdictions, and working out exactly how that will look across different specialties would go a long way to trying to support that hub and spoke model. The other thing that would be useful for that as well is being able to afford time to work across different jurisdictions. So as you say, you have to, in order to remain specialised, you have to be able to see enough people with a certain condition, and sometimes it's not enough to just see them in an outpatient clinic. You need to be able to go to where things are happening. So there were previously, again from the cardiac network point of view, there was one of our cardiologists and one of our anaesthetists who went down regularly and continued to do cardiac catheterisation lists in Crumlin. But unfortunately, it wasn't really in a supported way, and they lost that position about a year ago. Crumlin brought in somebody else to take a full-time post, basically, and they lost their list. So we now don't have a specific... We have regular meetings with them and regular updates, but we don't have somebody who's actually on the ground in the Children's Hospital in Crumlin, getting that engagement and bringing that expertise back. So there is a real need to give clinicians, other members of the workforce time. If you're working in a very specialised area, often it can be very focused on just service delivery rather than how do we make sure that people are keeping their skills up, how do we support people's registration across different jurisdictions. So it is quite difficult. My colleagues who work in NISTAR with me find it very difficult to actually get their registration pushed through with the Irish Medical Council and the Irish Nursing Board. So we have difficulties with even getting our staff to do transport, but if they were going to go down and work in the new Children's Hospital or go down and do clinics in the Children's Hospital in a true sort of hub and spoke model, that registration process would need to be sort of streamlined a little bit and sped up. So I think there are things in there to try to get better working, or to compel the bodies to kind of work in a more streamlined fashion or a more efficient way, because we are unusual. Other parts of the UK are not trying to do this, so therefore the GMC are just saying, well, we're not really that interested, because there aren't a bunch of people in the UK trying to get registration with the Irish Medical Council. But we have a very specific problem, and the solution for it is compelling these bodies to work closer together and to recognise each other's training.
Can I just answer, Ms. Dillon, specifically for Duchenne muscular dystrophy? There is a gold standard care for Duchenne muscular dystrophy patients, and they should be seen in a multidisciplinary clinic with their adult colleagues to whom they will transition, which also covers the transition argument and concern, and where their psychologists would be in place. And we have been advocating that for many years within the Children's Hospital for that particular service. There are new therapies for Duchenne muscular dystrophy children currently, which are not able to be offered or delivered in the Children's Hospital. There was a multidisciplinary clinic which addressed all of those concerns, had psychology, but again the service was removed because of lack of funding. So the paediatric neurologists know exactly how to look after these children. They're just not able to do it because of financial and systemic barriers, which are so easily surmountable if we could have that funding and the backing from people like yourself.
I think
it is something. Sorry, just to say, it is something I'm raising on a regular basis with the minister right across actually paediatric services, or the lack of, to be honest with you, is more what I'm raising, to be perfectly truthful with you, and lack of ability to access services. So it is something that I am raising on a regular basis, and I will continue to. But I would be happy to engage with you separately outside of this, just to make sure that what I'm raising is actually relevant, and that we're working, I suppose, hand in glove to try and make things better for our children is probably. So I'm happy to engage with these further. I'm conscious other members do want in, but I definitely would like to have further conversations around that. And I suppose in terms of our own actions as a committee, Chair, I would definitely say we need to write to the Minister to find out what work has been done to address that issue about the north-south. That's really, for me, is a really concerning one, particularly given how well that the cardiac surgery for children has been operating. I would hate to see that we would come up against a challenge because of a failure to address what effectively is an administration issue.
Thank you.
Nuala?
Hello. Thank you very much for your presentation. And I know I have met some of you. Julianne, we've had a tour of the children's A&E, Danny and I, last year to actually see some of the issues that you have raised, in particular like the trauma centre, some mental health issues within the A&E department in terms of the services that are offered there. So that was a great opportunity for us to learn a little bit more about the regionalisation of our children's services. And obviously it's great that we are getting the new build, but it's just coming so late. My questions are actually arising from some of the things that you've said in the introduction and in your previous answers. And just first of all, I'd like to touch on this regional aspect of actually dealing with the waiting lists. The Health Committee also had a visit to Daisy Hill Hospital and the Southern Trust regarding their a number of their services, and one of them when we were there was about their paediatric waiting lists. I can't remember which service it was. I'm assuming paediatric surgery in general, about their offer and what they can do for regional services, and I think it's really important. Just if you have any other comments on how regional services can work and how important they are, that it's not just Belfast Trust, because that's the worry is that it's just always going to be Belfast centric. But here we were seeing in the Southern Trust that actually hospitals like Daisy Hill could actually operate these services there.
Yeah, thanks, Ms. McAllister. Yeah, we agree. Regional services are part of the solution. And certainly when we launch our Worried and Waiting Community report in a few weeks' time, that's very much the model that we're proposing for that one specific problem. For example, the general paediatric waiting times in Daisy Hill are not too bad, whereas their autism and ADHD waiting times are very bad indeed. So definitely there's a scope for a regional approach to managing the outpatient medical waiting lists.
And in terms of Daisy Hill, I think specifically what you're talking about there is the surgical waiting lists and how they operate. So Erin Milliken, who is one of our surgeons who is on the Child Health Partnership, has worked really hard to make sort of services that are children friendly, that they can operate in regional centres to bring down waiting times for, across Northern Ireland, and that the paediatric surgeons can then concentrate on specialist surgeries that have to happen in the children's hospital. So they're going out to Daisy Hill, to the SWA, to operate along with their adult surgical colleagues who are commissioned to operate over 5 years old, so that they, familiarise themselves. The anaesthetists are working with anaesthetising children, so you're building that sort of robust network of skill, expertise, and that, all of that expertise is there whenever you need it in an emergency as well in all of those regions. So it's not that everything is Belfast centric, although some services do need to be regionalised, that the whole network and the paediatric network is supported with problem solving pragmatic solutions to, problems that are already in the system.
I think that is very important to note, that it's not just about Belfast and the services there. But then I am going to circle back then to the distinct aspects of the children's and actually being able to manage the services that are delivered there. And I know I understand this is mainly about paediatric waiting times, but it does lend to that. When we were there, I know, Julianne, that it was raised the issues of mental health and the facilities and services there. And one of the aspects was that during COVID, in order to help colleagues from the adult hospitals, the children's took on more of a role, but were never funded for it, but it was never then taken back off. Is that still the case now? And how is this actually affecting services? And what are the facilities like for actually holding or being able to actually help young people who are in times of mental distress?
Yeah, so in 2020, Easter of 2020, to help our adult colleagues in the COVID-19 pandemic, we had a temporary uplift from 14 years to 16 years, and we're still, on 5 years later, on a temporary uplift. And you're absolutely right, there was no funding or resource that came with that temporary uplift. And that in particular affected the children and young people who are presenting with mental health problems. So, I see children in complete distress day and daily. You know, they've self-harmed, they've threatened to take their own life, they have eating disorders, they are emotionally and mentally dysregulated. There are children with learning disabilities who have such extreme behaviours that their parents are devastated. They have nowhere else to turn to, so they come to an emergency department, and that happens right across Northern Ireland. It is so distressing for the child, for their parents, and for the staff that look after them. We've had to have a new anti-ligature safe room. We have that now. The moral distress of having to look after these children who, you know, the services are not there to help them in their times of need. So you know, the community services, which are completely lacking, and we'll tell you about in 3 weeks' time, you know, the social services is not there to help them, and they come to us because they're desperate and they're just at breaking point. And for us, you know, it's really difficult because the services just aren't there to refer these children on to. So we're patching these children up to send them back to environments that made them sick in the first place. And the moral distress for our services and for our workforce is, you know, it's heartbreaking. But we can only do our best with the services that we have, but it could be so much better, you know, for our children. It could be so much more robust to, you know, holistically support these people who are often in crisis, you know, because of the socioeconomic distress in which they live, because of poverty, because of, you know, lots of other issues, which I don't need to tell you about because you're well aware of them. But, you know, for us as clinicians, it's so difficult. And you know, we're failing an entire generation of children. So, you know, these children will grow up to be adults. And if we get it right, if we invest in early years, if we invest in, you know, getting their sort of psychological supports, and there's lots of children who are mentally ill, but there are lots of children who are just emotionally distressed. You know, life isn't easy. And, you know, there's lots of things we could do in schools, you know, lots of things that can be done. And again, we have the solutions. We know what to do. We just need investment. We just need that for children to be front and centre of every single department so that we can solve these problems before they become a problem.
Just to highlight.
Absolutely, I agree with that, and I think it's really important that these issues are given that public attention in a health committee such as this. And it was certainly for Danny and myself that was an eye opener to some of the things that we did see. And as a parent who uses the child services, you know, on not a regular basis, I can only imagine then what it's like as a parent who does use the services on a regular basis, and before you even actually get to your first appointment, it's distressing. Like, I understand that there are other questions from other MLAs, but thank you very much for answering those for me.
I wanted just to mention as part of that, we were sent out the Healthy Child, Healthy Future sort of draft, which was produced by the department towards the end of last year, or maybe the start of this year. And going through it, it's meant to be from birth to 19 years old, but there's an obvious gap where there's basically zero mention of adolescence through any part of Healthy Child, Healthy Future framework. And you know, no mention about mental health, no real mention about transition, no mention about appropriate places for their care or where should be appropriate, or risk-taking behaviours, social media, smartphone. There's just all of the things that affect our young people that we're all concerned about. In this strategy that's meant to represent them, that is about children, they're still not represented. So I think that just to highlight a real discrepancy in that age group as well.
I mean, because you've covered it in that, but you've covered it in pretty much everything else that we've said. I mean, when the department or these strategies are being designed, is there no co-design? Like, I mean, that just sounds so basic, the point that you're making there, and I'm scratching my head thinking, you know, do people, when they're designing these, not speak to the likes of yourselves and others?
We did definitely do some workshopping for the obesity strategy, which I thought was all going to sort of come in and definitely raise these points at the time. But it doesn't necessarily always transition in, and transition.
And we certainly comment on as many as we believe are relevant to child health.
And we are then surprised to find that doesn't transpire into final strategies, even where that is pretty bad. Like the under 5s being identified as, you know, being the heaviest users of EDs, and you can imagine, you know, under 1s are frequent flyers. So and for them not to transpire into the actual strategy, and for us to move forward with an urgent care, framework without doing that for children is I mean, obviously with doctors here today, they can speak much more, to this than I can, but whenever you take your child to an ED, there's no differentiation between minors and majors.
I think the assumption is that people think children are healthy.
Yeah.
And yes, by and large they are, but for parents and for carers, when your child is sick, you lose the power of rational thought.
Yeah.
I have specialty training, subspecialty training. When my child is sick, I lose the run of myself, and that's the same for every other parent and carer across Northern Ireland. And the services should be designed for that.
Yeah.
When you're sick, you can make a choice, but actually when your child is sick, you can't really, because people are afraid, they're concerned, they're worried. We've set up a Belfast Trust symptom checker, which is as best as we could do. 2 of our paediatricians, Julianne Collins and Sarah Kapoor, took time, as well as having a full-time job, to set up a website to help people, if they have abdominal pain, if they have head injury. It's an easy way to look up, the red flag symptoms, the amber symptoms. But actually, we've been to the health minister, we've asked on a number of occasions to fund the Healthier Together platform. It's not a huge amount of money, but those things need to be maintained. They need to have governance. They need to, the things need to be updated. So we're trying our best to make this service a little bit better for parents and carers, but I think people need to understand paediatrics is different. Children are not little adults. They're very, very different. So Rory, Tom and I look after ex-premature infants who are born at 24 weeks, and we also look after 18, 19-year-olds. So there's a huge breadth of experience that is required, for that, and it's different, and it needs to be looked at and funded in that way.
Okay, thank you. Alan Robinson.
Thank you, Chair, again. Pretty shocking, shameful, sickening statistics presented today. I suppose another day in the life of the Health Committee. You made reference, Dr. Bourke, to the Belfast Trust running an online symptom checker. Now, obviously, the Minister is always keen to tell us that he encourages all trusts to be starting to think regionally and to think as one. In your communications with trusts or the department, have you put that ask to them? And what has their response been with regards to rolling out this on a regional basis? Obviously, we as a committee are always very keen for any nugget, anything that will be of any benefit to take some pressure off EDs, take some pressure off primary care, and as you said initially in your piece, that this does just that. So can you know what is the department or the trust response, and also the piece on the Healthier Together platform? What has been the response to date? And I suppose, Chair, it would be good as part of the number of questions that we're then putting to the department that we ask about the implementation of the Healthier Together platform and the online symptom checker that is run by the Belfast Trust. Just another question, just following on. I see in the workforce headline within your report, there was a line on it and it just intrigued me. It said the available data in Northern Ireland does not indicate how many paediatricians per grade are working in the system regionally. Can you just explain to me why the data doesn't show how many are working? Surely you're not meaning that the department doesn't know how many paediatricians are working within the system?
Do you want to take the first one and I can take the second?
So I'll answer the Belfast Trust symptom checker. So myself and my colleagues in general paediatrics and the emergency department set up the Belfast Trust symptom checker because we had gone to the Department of Health to ask for funding to set up the Healthier Together platform, which along with the Royal College of Paediatrics and Child Health is up-to-date standards, reactive network that is fully funded and has a governance, it's subject to governance as well, and that those requests were turned down by the Department of Health. So instead of that, we set up with Healthier Together, and we're using their intellectual property. So, you know, there are certain caveats to that. We can use some of their information, but a lot of the information we have, you know, come up with ourselves, instead of, you know, the whole Healthier Together platform, which has intellectual property, you know, has to be paid for, has to be updated. So we did ask for a small amount of money. I think it was 196,000 from memory, you know, to set that service up, and it was denied on a number of occasions. And because of that, then we set up the Belfast Trust Symptom Checker. We're happy for it to be used regionally, and we know that people do use it regionally. But again, Healthier Together have given us permission to use their intellectual property for the Belfast Trust. So, you know, there's a legal, you know, obligation as well for us to, you know, to use that. But absolutely, we're happy for it to be regional. We're happy for it to be expanded. We're going to develop an app for parents as well. Parents do use it. You know, it gets a lot of hits. So for example, in the measles outbreak, we were able to put up something about measles, what to look out for the Group A strep outbreak 2 years ago after a child died of Group A strep. We were reactive. We were able to put up, look, this is what happens when you get Group A strep. These are the things you need to look out for. These are the things you need to worry about. Red, you know, symptoms, amber symptoms, green symptoms. Really well received. The feedback we get from it is excellent. So, but again, we've asked and we've been refused funding for that. Similarly, you know, we've been asked for an online platform for mental health problems, you know, for when teenagers and young people are waiting to be seen by the child and adolescent mental health teams, for an online platform. And again, we've been refused that funding. So the bridge between that, because it is an online world now, and children, young people are used to doing that. And in the back of that, we developed a HEADS app, which is to be used by our children and young people. Our emergency colleagues developed that in their own time, you know, to help that, to signpost people with, you know, addiction problems or bereavement issues, so that somewhere they can go. And the sexual health team now are taking that on board and using that, you know, to get messages out to our young people. So again, you know, we are proactive. We're trying to make things better. We have the solutions. We're not getting the funding or the backing from our Department of Health, which is really disappointing.
I guess that would be done regionally and by algorithm rather than by that amount of manpower if we were to commission Healthier Together. So that the value in return, we can provide you with much more data on this should you want to. There's quite a lot of data out there that kind of shows that it's pushing people away from EDs, it's pushing people are actually learning from it as well is the useful thing. You know, if they've learned something with their first child, they'll know that if that presents maybe in their second child or their child again. So there's just a general overall saving in the long run that is manageable from this platform. But in terms of the specific question that you asked around kind of workforce, the reason we put that in there is Northern Ireland is the only jurisdiction of the UK that doesn't publish how many paediatricians there are per capita. The problem with that is that leaves an awful lot of ambiguity as to where our paediatricians are working across Northern Ireland. It's small enough for us to understand, but it's something that we don't collate. That is probably made more complex by combined rotas of people that are doing maybe acute in general or community in general, paediatrics. So we actually aren't able to pinpoint in the public domain. So as a Royal College, we maintain a data library. And it's a big glaring omission on there that Northern Ireland isn't in a position to add to that, to let us understand how many paediatricians are working. Now, it's something that we would always say, if you follow the money back to the national insurance number, you should know how many people you have working and what they're actually doing. But at this point in time, it's very difficult for us to ascertain where our paediatricians are, what rotas they're covering. And then that makes it much more difficult for us to try to forward plan for all sorts of types of leave, for right up until retirements. We have consultants that are genuinely considering their retirement because they don't want to walk away from a service that's potentially may collapse without them. So we can't make long-term decisions from anything from ad hoc sick leave right up to retirement, and that's something that we really need to get out in front of. And the first step toward that is understanding the data behind it.
And the Department of Health have commissioned reports, you know, getting it right first time reports. You know, for my own service, emergency departments, any, you know, tier 1 emergency departments should have 10 whole-time equivalent consultants. We have 7 whole-time equivalent consultants. And we've asked for the commissioners for additional funding, and it's a no. So if you're going to commission a report and you're going to act on the recommendations of that report, we can't understand why we are left with not enough staff. Tom, Rory and I will be on rotas that have gaps where you're expected, and we will, of course, cover any gaps, but that's not sustainable in the long term. We have lots of interested paediatricians who are residents now in training programmes. They are, they've completed their certificate of completion of training, and there are no jobs for them. But we can see gaps in the service. The trusts are reluctant to go at risk monies. They have to have commissioned monies, to appoint these consultants. So we've trained lots of paediatricians who currently have no jobs as consultants, but yet we can see the gaps day and daily, which is farcical and is a failure of the system and a failure of the Department of Health.
Can I just say as well, I found it very refreshing. You said that the service is designed for the people who work in the system rather than the people who need the system. I think that was very refreshing to hear, and I wish some in the Department of Health would think that way too.
Paediatricians work for the children that we looked after. So after this meeting, I'm going into work in the emergency department, and I'll be there until the early hours of the morning until all of the children are seen and looked after. We work out of hours, we work weekends. We are not on golf courses or sitting having, red wine lunches. That's not what we're about. We are public servants. We are there to look after the children that we need to look after. And our service is designed by paediatricians who are generally hardworking, good-natured, and are often taken advantage of. And the reason that the service is sort of, floundering as it is now is because that goodwill is largely being eroded, because, there's only so much a body can do. And as paediatricians, we're here to advocate for the children that we look after. It's really unfair and it's inequitable how paediatrics is funded as opposed to, an adult service, which is largely designed for the people who work in it. Medicine is not a 9-to-5 service and should never have been designed as such.
Yeah, I'm running here to get my charger because the battery's flashing up here, so just in case I disappear off the screen. Okay. Thank you.
I'm going to bring
Mr. Robinson.
Danny, and we've run way over our time, which is important because this is a very important issue, so I didn't want to cut it short, Danny, but a couple of quick questions, a couple of quick answers, because we have others to come on after you.
No problem. Thank you very much for that presentation. Obviously a huge range of issues and some very, very concerning issues. Certainly I hope we'll follow up the training issue with the Republic, and that'll be something that the committee can obviously look into. The one that really struck me was when you said, Tom, that based without the data that you haven't got because of the rollout of Encompass, but you think that the waiting lists are still growing by 6% on year. Was that correct?
So in fact, we do have data. The data we do have for the 2 trusts that introduced Encompass first show it's just for all of the other trusts we don't have the data. But nothing strategic was done since our report, so clearly the situation is the same. It's at least 6%, I would say.
If we dig way into NISRA, we can kind of ascertain the final quarter of, I think, quarter 3, quarter 4 in 2024, so that would cover December. If you look there, you can start to see some of the disaggregation, but in Northern Ireland total sits around 19,000. That completely omits the South Eastern Trust, and there's a disaggregation of paediatric neurology from that. So what we can infer from that number is that for the next 2 quarters, we're still going in the wrong direction.
Which is very concerning. We're having the same problems with data. You mentioned data again and again as being a solution, but there seem to be barriers to actually, unlocking that data and being able to use it. I hope that we can get that and we'd start getting more numbers, more usable numbers in the future. Just wanted to say one thing about your presentations of solutions. I thought that was fantastic today, that you are going out of your way to design and present solutions such as the symptom checker. And these things, obviously do reassure parents, they give them directions to go, and they reduce impact on A&Es. That's phenomenal when we're hearing from other areas within the health service that there's so much pressure on A&E. So here's a solution that will help. and I hope that we can have a look at how that might be able to be funded and moved on. So thank you for that.
We've lots of information because we've been before, so we you know, you can come back to us and we can give you that information.
I'll take you up on that. Thank you very much, Julian. Thank you.
So thank you very much. As I say, we've run way over time, but it was really important. It's a really important issue, and it was very important that we heard everything that you had to say. And as I say, we'll probably have a raft of actions for ourselves on the back of this. So thank you very much.
Very grateful.
Thank you so much, Chair and Committee, for listening to our concerns. Thank you.
So, members, I'm just going to ask the clerk to kind of run through actions as a result of that, so we can get agreement moving forward.
So, just a few issues that were raised by members about further information was, first of all, in relation to the breakdown of funding provided to address paediatric waiting lists. What work is being done in relation to the issue around the North-South training and recognition of training, and ask about the implementation of the Healthier Together programme and the rollout of the symptom checker in the Belfast Trust.
Yep. Yeah. So everybody happy with that? Linda?
Just when we're asking what work is being carried out, if we can specifically ask, has this been discussed at North-South Ministerial Council level? And if so, what progress has been made? And if not, why not and when will it be? So it's kind of...
Okay. Members, I'm going to just jump now to the SR, because I'm conscious there's only 6 of us here, and there's others who have said that they're going to be leaving early, so we're going to do the SR and then go back. So item number 8 on the agenda, SR 2025/100 on health and social care pension schemes. So there's, can I refer everybody to tab 8 of our pack, and that includes a clerk's memo, page 83, SL5 at page 85, and then the SR itself, which is at page 86. There's also an explanatory memorandum at page 106, and the report to the Assembly is at page 111. So this committee considered the SL1 on 15th of May 2025 and agreed it was content with the merits of the policy proposal. There have been no changes to the policy content since then. The Examiner of Statutory Rules hasn't yet reported on the technical aspects of the SR. Therefore, members will be agreeing to the SR subject to the Examiner report. So can I ask members if we're content with the SR? Yes, content. So just to formally put it, I need to ask members to agree formally that the Committee for Health has considered SR 2025/100, the Health and Social Care Pensions Schemes Amendment Number 2 Regulations NI 2025, and subject to the Examiner of Statutory Rules report, has no objection to the rule. Content. Okay, thank you. Right, okay, we're going to move back to the other item, back to item number 7. So this is an oral briefing from the Department for Health on Children Social Care Services. So can I refer members to briefing paper at tab 7, it's page 52. And can I welcome Eilís McDaniel, Director of Social Care Reform, Deirdre Mahan, apologies, retired Director of Women and Children's Services and Co-Chair of the Family Support Workstream, Kerrylee Weatherall, Interim Director of Children's Community Services and Co-Chair of the Residential Placement Capacity Workstream, and Jacinta Linton, Chief Executive, Bolster Community and Co-Chair of Family Support Workstream. So, ladies, you're all very welcome. 45 minutes for this presentation. I presume you've got opening remarks you want to make, and then we'll open up to questions from the members.
Thank you, Chair, and good afternoon. And thanks again for another opportunity to actually brief the committee on progress made in connection with the independent review of children's social care services and the associated reform programme. You've introduced my colleagues here, so I'll not do that again. We provided the committee with a briefing paper in advance of today's meeting, and the paper sets out what is being done across all areas of the reform programme and how that work relates to recommendations from the Children's Services Review. The paper also seeks to provide members with a sense of the next steps for the programme. As members will be aware, the reform programme has now passed the 2-year mark. It was first established in April 2023, and it's almost 2 years since the independent review published its report. The reform programme was established in advance of the review, reporting to start to tackle many of the issues that led us to initiate the review in the first place. The department considers that it's now time to take stock of what has been achieved to date and to re-evaluate what the programme is seeking to achieve, to assess whether the focus is on the right things and whether there's scope to refocus and to streamline the programme structures. The briefing paper sets out the intention to underpin the work of the reform programme with a 5-year strategic plan with a clear vision and focus on a small number of strategic priorities. Thank you. To drive meaningful and sustainable changes across the system. A draft plan is in development. A number of strategic priorities have been identified, and your briefing paper sets out 5 of them. We will be engaging with stakeholders to make sure we've identified the right priorities and the right actions to deliver against them. I need to caution that these may be subject to some change, but I can say that supporting families at the earliest stage to enable them to stay safe and well and together must be a key focus if we're to make a difference for children and families in the longer term, and to begin to reverse the trend of sharp increases in the number of children that were taken into care and the rise in the number of children with child protection plans. The need to enhance support for families in Northern Ireland was one of the main themes running through the review report, and many of the review's recommendations are aimed at improving support at the earliest stage for families in Northern Ireland. Recommendation 22 call for a reset and refocus for children's social care services to give greater focus and attention to family support. The family support work stream of the reform programme, led by Jacinta and Deirdre, is working to deliver on that recommendation, bringing together statutory, voluntary and community sector partners who share a vision to make family support the way we do business in Northern Ireland. And Deirdre and Jacinta will be able to take members through in more detail what they have learned to date, what they think is missing, and what they think the direction of travel should be. However, it's clear that investing in early health for families is one of the most impactful and cost-effective actions we can take to improve the lives of children and families. And we know that when families get the right support early, both early in a child's life but also early in the life of a problem, children are more likely to thrive, to avoid harm, to live healthy, more successful and happier lives. The case for early intervention has already been made. I think that's beyond dispute. Research by the Early Intervention Foundation that was undertaken in 2018 shows that for every £1 spent on early intervention, up to £9 can be saved in future costs by reducing the need for expensive crisis interventions, such as state care, taking children into care, hospitalisation and youth justice admissions. Indeed, the research is compelling, indicating that positive early years intervention reduces reliance on adult mental health services, heart and diabetes services, drug and alcohol services and the adult justice system. And this is why the Health Minister sought support from the Executive for a cross-departmental discussion on a family wellbeing fund. And Scotland is already reaping early benefits from their whole family wellbeing fund, which is a £500 million investment over the life of Scotland's current Parliament to support whole system transformational change, to reduce the need for crisis intervention and to shift investment towards prevention and early intervention. And while an equivalent investment of this scale in Northern Ireland is unlikely in our current financial circumstances, some additional investment is needed to start turning the curve and to reverse the current trends for families in Northern Ireland. We're clear that this is not something solely for the Department of Health. It's not something that we can do alone. If we can prevent children coming into state care, and we're also likely to prevent their exclusion from school, for example, their involvement with the juvenile justice system, or their admission to the juvenile justice centre. It's also likely to make for a much brighter future, the prevention of homelessness and a reduction in the risk of poorer health outcomes. And I know that that's a very strongly held view of Deirdre's and Jacinta's. However, while we want to see the preservation of family relationships and a reduction in the number of children being taken into state care, it's going to take some time to see the impact of this early intervention. And currently, for some children, an admission to care may be necessary to offer them protection and to promote their well-being. And when we take children into care, we have both a statutory and also a moral duty to provide the best possible quality care for them. And that means being matched to a placement, to a home, best suited to their individual needs, where they have stability, a greater sense of belonging, and able to forge consistent relationships with carers and staff. Above all, care should be a positive experience with positive outcomes and with time invested to help them prepare well for life beyond care. Unfortunately, this is challenging in the current context of sharp increases in the number of children being taken into care, greater complexity of need in the children's population, and fresh challenges posed by, for example, the growth in the number of unaccompanied minors arriving in Northern Ireland. The struggle to meet demand is leading to a reliance on more costly private placements, including out-of-jurisdiction placements, under what we call the extra contractual referral process. It's also leading to homes having higher occupancy rates than policy stipulates, and the use of unregulated placements. Given the projected 18% increase in our looked after children population by 2029, and that's what Kerrylee's work is showing at the minute, enhancing the capacity of our residential care provision is essential. And it is the focus of the residential work stream, as I said, which is being co-chaired by Kerrylee. In the last year, there's been a thorough examination of provision, how many homes we have, where they're located, how many children they accommodate, how they're staffed and managed, and how we invest in them, with comparisons made with foster care, for example. Alongside an examination of provision, we have also taken time to fully consider the profile of children in residential care. And we're trying to determine what we need in the future, not only to meet a greater volume of need, but also greater complexity of need. Providing a placement or home is only one part of the solution. We also need to offer children therapeutic supports to address the early childhood adverse experiences that led them into residential care in the first place. The outcome of the work being led by Kerrylee will be a regional strategy for children's residential care in Northern Ireland to be implemented over the course of the next 5 years. By taking a regional approach to the development of the strategy, the intention is to develop a residential estate that serves children across Northern Ireland, with the introduction of smaller homes where they're needed. Homes which offer greater flexibility so that children don't have to move on, and more specialist provision to prevent children having to access out-of-jurisdiction care, and also to address some of those newer challenges that we're experiencing in recent years, with more children actually coming into Northern Ireland without being accompanied by a responsible adult. Kerrylee will be able to take you through the findings of the work that she's led and any emerging proposals on the way forward. I understand that one proposal is to develop earlier intervention and prevention options focused on children at risk of entering care. And this includes working with the wider family and the community support networks to either prevent some children and young people becoming looked after, or to support and maintain their discharge from care. Another proposal is the establishment of an intensive edge of residential care service, potentially replicating a model in one trust area which, based on early evidence, has successfully reduced admissions to residential care and supported fragile foster placements. Or also another option is to modify and apply other well-established and evidence-based models from elsewhere. Other proposals include the development of a range of short break shared care and outreach provision to again either avoid admission to residential care or to support early discharge. By way of the paper provided in advance of today, we've tried to give members a sense of progress being made under the Children's Strategic Reform Programme, and I do consider that we have been making a lot of progress over the course of the last 2 years, but also to advise you of our intention to do that reset that I've talked about, a refocus on a smaller number of strategic priorities that not only address ongoing challenges within children's social care, but also enable the implementation of the accepted recommendations from the Children's Services Review. Just want to give you a reassurance on that point. While we're changing tact, we will not lose focus on the recommendations from the review. We are developing a strategic plan, and we'll share that with committee members at the earliest opportunity. It'll be supported by an outcomes framework, which we don't have at the minute, so and also a delivery plan setting out very clearly what actions are going to be taken forward, who's going to be responsible for them, when they will be delivered. And it will also include, again, something that we don't have at the minute, a very clear vision and priorities that we need to focus on. Thank you for the opportunity to offer an opening statement. I'm very happy to take questions that members may have.
Thank you very much. Just going to go straight to members. Nuala.
Hello. Thank you. Hope you can hear me. And thank you, Eilís, for that update. I have a few quick questions here, just to fire through them. Just starting with the first strategic priority update. Just some of the questions that I have was about the foster regional rate. So it says there's going to be an interim regional rate for befriending club leaders and short break carers. Is there, or has that already been done before? That's just a quick question.
So I don't think it has been done before. So I mean, we do want to set a regional rate, but to be able, that's going to take a bit of time, Nuala. So to be able to move some support measures on, like providing families with befrienders, etc. And I think this is linked to the Minister's 13.1 million fund for children with a disability. So if we can set a rate for those kinds of positions, then that can be applied consistently across the region. While we're doing that piece of work, that'll take a bit longer to deliver.
So this is to help people to have, no, it's not for, this isn't specifically for the respite, but for, like if you want like a day break, or?
Yes, absolutely. So befriending is one bit of it. It's just another support mechanism, but ensuring that when trusts are providing that support mechanism, that they're paying people consistently or a standardised rate across the region. And you're quite right, it will include day short break care, not overnight short break care.
I think that is important, that day provision. Another issue then that I think might arise there, Eilís, I think you were at the previous health committee whenever I talked about the delegated nursing tasks, might not always come into play, but for some people, it, being able to actually utilise the service and ensure that people can actually carry out the tasks is important. The next question on the priorities then, sorry, I'm just trying to get it up in front of me here, is about the 13 million. Are we at a stage yet where we can actually say this is how many respite beds that it has delivered? Because I think we are past a quarter now, in terms of like if it's quarterly reporting. Are we able to actually look back and think, okay, how many beds were we able to increase then? Or do you think that's something that won't be able to be done until this current quarter that we're in?
So I don't have any figures for that at the minute, but I do know that some of the expenditure last year was assigned to short break residential provision. How many places, Nuala, were purchased, I can't say with certainty here today, but that's something we can get for a committee. All of the trusts, I think, now have produced their implementation plans, so what they will be doing over the course of the next year. I think they're with the department at the minute. I understand that officials are coming to committee, not coming to committee, providing a briefing paper to you within the coming weeks. So I can make it clear to officials that that's the kind of detail that you would like to see represented in that paper.
Okay, thank you. And then moving on to the second strategic priority and those recommendations within the briefing. It was just about the residential care capacity explored, and you actually just said it there as well about the multi-use. I know whenever there was there was a conference, I think I can remember at some point last year, that we had discussed and touched upon the use of a permanent residential place and short break residential place, like multi-use on one site. Did we get any further with that policy, and whether we were engaging with RQIA on that at all to see where that can be explored?
So I think there's a paper nearing finalisation, Nuala. This started during COVID, when there were a number of residential homes that put in place what we called at that stage annexes, and that enabled them to do a number of things. It enabled them to maybe move children around more easily. If you consider that during COVID, children were in the home for quite a lot of the time, so it enabled them to move maybe some children who were experiencing some level of difficulty into that annex arrangement, and it also enabled self-isolation and that kind of thing. And that was the genesis of us looking at multi-building children's homes. So a paper is in production, so there's a piece of work being co-led by the department and the RQIA, which is considering how we might do that in Northern Ireland, and that will be presented to Kerrylee within the residential work stream, and then ultimately to the reform programme board.
Okay, I'll look forward to that. I know I have asked about that for a few times, so it'd be interesting to hear where it actually goes in the end. And this is a quick question. What you mentioned about unregulated residential placement, so can you just give us an example of what that might be? I'm not sure. When you said I was unsure about what an unregulated residential placement.
So an unregulated residential placement could be a placement, for example, in a B&B. But the department has a very clear policy around this, so we make it very clear that it should only be used in emergency circumstances. Only if there isn't an alternative placement available, must only be for the shortest time possible, and there's also an expectation that there will be support provided to that young person, both to safeguard them and make certain that their needs are being met. There's also a requirement to report that kind of placement to the department within 48 hours. It shouldn't be used very frequently at all. Unregulated placement can also be used in connection with a kinship care placement that hasn't been fully through the assessment process. So when you hear the term unregulated placement, do not always read it to mean an unregulated residential placement.
Okay, yeah, I think I have had actually outreach by a social worker who had stayed with a young person in a B&B. Actually, they had two at the time. So I didn't think that would be what it was. And my other question is about the state of and the transition between day services and out of hours services. I'm not sure if you're aware, but there were a number of weeks ago in which a young person at one of our schools, and I'll not name the school, did require intensive support, and the GP had signed off with regards to detaining the child, and an approved social worker was needed. Now, this happened at 1 p.m, 1:30 p.m. on the school day, and it wasn't until 9 p.m. that night where the child was finally found a place and at a residential site for intensive mental health support. But as far as I'm aware, and I was in touch with the family, I was directly in touch with social services to escalate, that the day services were aware of this child, that they had received phone calls, and that it was just transferred out of hours at 5:15 on the Friday. This I don't know why it took so long you know, for interventions to take place whenever the principal at that school, teachers stayed on with this child until quite late at night. But the reason why I raise it here is it's not the first time either. We've also had other instances where the day services have transferred out of hours. And it's on a Friday, it's transferred out of our service. People don't know who to call or where to go, and it seems to be a bit disjointed. I just wonder if there is any review or anything to being looked at with regards to the transition of emergency situations from day services to out of hours. You know, because whilst that might not happen very often, it was a very, very distressing incident. And I just don't know if this is something that you've heard, you know, other than the two anecdotal stories that I bring up, but because of the severity of it, I did feel that I should bring it up here today.
Okay, so I am aware of the case, Nuala, that you're speaking about, but without getting into the detail of the case, is there anything that you can comment on, Kerrylee?
Yeah, Nuala, I'm aware of the case, and there was a lot of planning that needed to take place in those hours in the afternoon time. There was a multidisciplinary meeting that needed to take place. So the decision really to admit the young person, first of all, there had to be an assessment, a mental health assessment. And the decision was taken really around 3 o'clock, 4 o'clock following the meeting, that was the course of action. And then it needed to be looked at in terms of finding the most suitable placement. And there was 3 options. We had to look at what was the safest and best option in the interests of the child. So we did liaise closely with the school during that period. Now the school did go beyond their duty by staying open, and we were very, very grateful for that, because safeguarding is everybody's business. So we were very grateful for the partnership with the school in relation to that. But the reality is that we do have to have multidisciplinary meetings. We do have to make sure that we have made the right decision for the right course of action and source the right placement, because we do have placement shortages. And in that case, an options appraisal had to be undertaken, and we had to, there was other factors that had to be considered about safe transport for the child, how we arrange that. And we did really need the cooperation of the school to stay open until we were able to send social workers out. So by the time daytime knew about the case, because we needed to have the multidisciplinary outworkings, because we needed to have the options appraisals about the right placement for the child, and then work out the right transport arrangements and the safest arrangements, it would have fallen into out of hours social work to take over. So that was why it wasn't a straightforward issue that a child would be admitted to a ward in a hospital the way it might happen if you were in the acute sector. In the community, we had to look at a range of options that did take time to consider.
I think just in all of this, like, you know, the communication element is key. However, and we have had many different elements of the Department of Health and the trusts come before the committee, that have said, you know, we don't necessarily procure for this, or we don't necessarily do this. It's about, you know, getting places available where places are available, the right places at the right time. And I completely understand that, that it had to be the right option. But I do think, you know, still 9 p.m. at night, 1:30 when the GP arrived is a long period of time for meetings to take place and for options appraisals to take place. I mean, we know what exists and what is available in terms of what actual services exist, and therefore finding what case. Like, I know it's difficult, and the issues is very difficult indeed, but my worry is also that this is not the first time where the transfer of services from daytime and out of hours is, and I'm not saying the word lost as in there was neglect, but it isn't as smooth as what it should be. And is there an issue there about how it's run in terms of not mean people, it being a regional service or a more local service when it is out of hours? Because it isn't, and I say it's anecdotal, because I don't have the capacity to carry out a review of what those services look like. But it's not the first time. NGOs have also raised this with us as an issue, as well, when it comes to the out of hours service. Hospitals as well have raised the issue too. So it's just something that I think that we might have, it might be worth exploring further, and perhaps you could best assist us in how to do that, what these out of hour services should look like in terms of the emergency response.
Yeah, just to give you some assurance, there is a 4 o'clock meeting every day run by SPPG. So every trust would attend that meeting to look at the demand and capacity, so forecast for that day. So there may be a lot of handovers given to the out of hour service at that meeting, which also makes it very difficult and challenging for the out of hour service to deal with new referrals coming in as well. So there is a demand issue that's affecting services, daytime services as well as out of hour services, and it's a throughput issue as well. But happy to come back and brief you on it, Nuala.
Okay, thank you, and I appreciate taking up a lot of time, so I can put my other questions in writing.
Okay, thank you, Nuala. Linda?
Thank you, Chair, and thank you to you all for the briefing. Just my first question is just in relation to, you said that you would be speaking to the stakeholders. Can I get a sense of who that is? I'm probably thinking specifically around the Reimagine Children's Services.
Okay.
But I'm wondering, have they already been engaged with it? Have they been involved? Because I know that they are part of a group that obviously does engage with the department. So have they already been involved in this conversation?
Specific to an issue, Linda, or just generally, do you mean?
No, sorry, you had said you were going to engage on what's going to be produced in terms of a report around children's services going forward.
So, I mean, there will be, so the programme itself has a lot of representation by a lot of different organisations. So the reform programme, Linda, has a number of different departments on it, a number of different agencies on it. The voluntary and community sector is represented on the reform programme, but it's also represented throughout the programme. So the work stream that Kerrylee, Deirdre and Jacinta work streams, that they lead will all have voluntary and community sector representation on them. I co-chair a work stream with Michelle Janes from Bernardo's, which is specific to the relationship between the statutory sector and the voluntary and community sector. So that work stream, for example, was responsible for the organisation of the conference that took place last year. We're now working on the funding relationship between the sector and statutory services, and we're planning to have a seminar, for example, next week in NICFA. So I just want to assure you the voluntary and community sector is very much plugged into the programme in all its parts.
Yeah, I think that it's extremely important, particularly when you talked about, that I suppose the service you said you do not want to use with B&Bs, where potentially they could be a better service to engage there. I mean, we've been given examples before about where 2 social workers have spent the night in a hotel with a young person. I mean, that is not a good use of resource. I'm sure nobody would disagree with that. So I really think that in terms of using the voluntary community, and I'm very conscious, obviously, that Jacinta would be well aware of the benefit of having the charitable and voluntary community sector, and Liz was extremely complimentary about the service that you provide, particularly in terms of that early intervention and prevention, and I mean, that's where we want to be. I agree with you all, but unfortunately some young people, and I'm particularly concerned around this because I attended an event where a young woman had unfortunately ended up in care and had ended up in exactly that kind of a care setting. She was a victim of a sexual assault and she subsequently took her own life. And that's public, so I'm not saying something that hasn't already been said. I'm not saying the names, but actually her name is out there. Mummy has told her story. So I suppose in terms of that, it's just about getting a sense of that. Just then, in relation to the workforce, I think I'll just need to double check which strategic priority. I think it's 4, is it?
It is, yeah.
Yeah, so around the developing a safer staffing framework for social work. So obviously that is there, and I think that's definitely a positive thing because we really need to see that work done, but there's nothing confirmed in terms of implementation date our commitment to funding. So I'm just wondering if you can give us any confirmation around when the framework will be implemented and whether dedicated funding will be provided to ensure I can almost talk, safe staffing levels are achievable across the trusts. And I know there are other challenges. It's not just a funding challenge to safe staffing levels, but it is a major challenge because, like in nursing, we're being told that what we're being told the vacancies are what has been advertised for rather than what is needed.
Okay, so on the issue of safer staffing, this has been led by the Office of Social Services within the department, so by Anya Morrison, who's the Chief Social Worker. Draft guidance has been produced and it has been circulated for comment. One of the things that I understand needs to happen next, so it's making recommendations around caseload in terms of a range. So depending on where you work within services, there will be a recommended caseload range within that guidance. So that will need to be tested then. So here's what we're recommending, here's what we currently have, and we need to see whether there are any challenges in making that a reality. I think it has been acknowledged, Linda, you're quite right, to do this and do this properly. It is going to have to be resourced, and we will have to have sufficient numbers of social workers to be able to manage those recommended case loads. Whether additional funding has been secured for it as yet, Linda, I'm not certain. Again, it's something that we can find out for committee.
Yeah. If you can just come back to us on those couple of questions, and then just obviously whenever, I mean, it's out there for conversation now. We as a committee will obviously engage directly with the unions that represent social work. But if there are any particular issues that are being highlighted, just let us know. We cannot help if we do not know. So I'm saying to departmental officials, and not just departmental officials, anybody that's coming before us, just be candid with us. Tell us how things are, and our job is to hold you to account. But we want honesty so we can actually be a committee who is helpful. So I suppose that's my ask of everybody.
Okay, thank you for that, Linda. We will take you up on that offer. Yeah.
Thank you, Chair.
Can I just ask how many recommendations are now completed?
So there were 53 recommendations in the report. 35 of them were accepted by the department. There are a number of that are outstanding at the minute. Of those 35, you need to bear in mind that 8 of them we categorised as guiding principles. So they say things like you need to engage with people in the process, you need to consult with people, you need to act quickly at pace without drift and delay. So there are 27 accepted recommendations that have now been located with the programme. Work is continuing on all of those 27 recommendations.
None of them are complete?
None are complete.
And time frame for when?
And that's what you will get by way of a new delivery plan, very precise time scales then and time frames within which things will be completed.
Thank you very much, ladies. That was been Danny. Sorry,
I
go ahead.
Put myself in there earlier. Thank you for that. I was going to ask the Chair's question just about how many of the recommendations have been completed. It's been 2 years since the report. We've had Ray Jones back here giving us an update. We've talked with some of the young people with lived experience of care. I've met them on various occasions, and I know they're not seeing the changes on the ground. It is very disappointing to hear that none of the recommendations have been implemented in 2 years. You know, I think that's shocking. I think they'll be very, very disappointed to hear that. And can I just ask, following on from what Linda was saying just about engagement with young people, what level of engagement are you having with those young people with lived experience about developing this further? Are they engaged with the process at the minute?
So That's one of the things that was done recently. So each of the work streams will be engaging with children and young people, but the programme as a whole is now developed what we're calling an engagement framework, and the intention is to use existing networks to engage in things that we're developing proposals around. Is there any examples that you can give of where children and young people have been engaged in your particular areas?
So, for example, FOIPEC would sit on our workstream, residential workstream, and when we were looking at our strategy and the strategic plan, we asked their views and the work that they've already undertaken, and what does good residential care look like? What do you want your home to be like? How do you want to be treated? You know, and lessons learned from leaving and aftercare. Young adults that have left care as well. So really instrumental, and we're finalising strategy at this moment in time, and it's our young people that are actually designing the cover. They needed to understand what the strategy was about to design the cover for the strategy. So we have engaged fully with young people. They're a key stakeholder as part of our residential work stream, and I know that has been a drive throughout all the work streams to make sure that the voice of the young person, the child, the parents and carers as well are part of the co-production of any strategy that we're striving to execute.
Can you point to something that their voice, their opinions on this, which is expert by lived experience? You know, they are living this, they see this. Where has that provided a change? Where has that provided a change, an uplift in the care that is provided?
Well, I suppose some of their views, when we ask them about their lived experience, at the moment we have children's homes, and the majority of our children's homes do have high occupancy, and there are a lot of children with complex needs, and they are competing complex needs. And we know that children, there's a new Northern Ireland framework of therapeutic care that has been introduced throughout the homes, and it's very inclusive of children, and we hear their views, but it isn't in all children's homes because it needs to be resourced. But this is about helping children recover and build resilience and trust adults again, which is really, really critical. And it puts a team, a multidisciplinary team around a child, and it's intensive. And it's the first that it's really happened in our children's homes, because our staff are very well trained staff, but this is a different layer of how to actually support the recovery of children. So through that, children have been given really positive feedback. We have seen change because we've seen less incidents in the children's homes where this therapeutic framework has been implemented. We are hearing children's views more. And children are saying to us, the homes are too big, we want to feel safer, we want smaller homes. And that is part of this strategy, what we need to look at in terms of what type of differentiated homes do we need, because we have a plethora that we have to consider. We have homes for children that are going through intense trauma. So perhaps there is substance abuse, perhaps there is CSE, perhaps there is criminal exploitation, and they need to be, it would be more suitable, more appropriate to be in a smaller home. We have children under the age of 12. It would be more suitable if they were in a 1 or 2 bedded home rather than a bigger home. So there are there's step down that we have to think about for children coming out of secure accommodation or Beechcroft. It might be better for children to come into a smaller setting to integrate back. So there's a wide spread of need that we need to consider in terms of asks for investment.
Are you happy that those organisations who are providing that experience and the voices of those people with experience, are they convinced that their voice is being heard?
To the extent that we have voluntary organisation that has probably the most representation of children in care's voices, and through our own network, all 5 trusts sit in the residential work stream. The trusts are the main providers of residential care. But it's something that we always have tabled.
Okay, so there is ongoing engagement.
It is ongoing.
Did you want to say something?
Yeah, Danny, if it's okay if I could come in there. I mean, my expertise is not around residential care, and that's more Kerrylee's, but I hear what you're talking about here, and the voice of the child is key to where we're going. I'm sitting with Airdrie, co-chairing the family support work stream. I live and breathe family support. I've set up a family support charity 20 years ago, so it's in our DNA. And what I would say to you is, in the DNA of the Reform Board is the voice and aspiration of children. So it doesn't have to sit separate, it's part of everything we do. I also would ask you as politicians for your support. We currently have a raft of research ongoing at the moment through Workstream 9, and we can only go as fast as the resources that we get back. So I'm going to challenge you. We have a survey out at the moment which is for children, young people and parents to give their voice on what family support is, particularly to help us shape this strategy. It's live at the moment, and I suppose it's really important that I say this to you guys, because it's easy to go to the usual suspects. It's easy to go down the usual traditional networks. You know, we rely heavily on CYPSP structures through locality planning, through family support hubs, and out into the wider networks. But we're doing this through social media. We're doing it through LinkedIn. We're doing it through Facebook. I mean, just to put this in perspective, we coordinate the family support hub in Uri, and when we put out an emotive message on our Facebook, we will get maybe between 5 and 12 Facebook messages. They're not referrals, they're requests for help that come in between, you know, kind of 7 o'clock at night when the kids go to bed till 2 o'clock in the morning. So that voice is captured. All of that data that comes through the hubs and locality planning, including the voice of the child, they sit very much to the fore of that. That's reported up to outcomes and right up to SPPG through the sort of regional data. But I would ask, you know, I suppose there's a frustration from me, and Linda, thank you for the good work from Liz. It was well noted, and she left this committee far too early, but I had hoped we'd get here, sorry Philip, but I thought we'd get here when Liz was in the ascendancy, and we didn't. So look, can I get on the soapbox a wee bit about, and Eilís will probably kick me under the table here about some of what I want to say, but we can't do this without you guys. We need to shift the narrative from systems thinking and put children front and centre. We can't turn this juggernaut without you guys championing children. One of the things this morning, Deirdre and I were at CYPSP in Dungannon, and we put a rocket under a few people's backsides in terms of the chronic underinvestment. So Northern Ireland has a disproportionate percentage of children. So I mean, that's a very negative way of saying we've got more young people. But historically, only 14% of the budget for health and social care services is spent on children's services, and NICI has told us this from 2007 with consistent calls for more investment. This translates to significantly lower spending per child in contrast with other regions such as Scotland, for example, which is 44% by contrast. So Red Jones' review explicitly highlights fragmented and inconsistent funding. We had a conversation outside with Eilís and earlier with Deirdre, where we talked about the wonderful shiny projects that have been resourced and delivered in Northern Ireland, and when the money ran out, they are mothballed. And we look to the next shiny thing. We need to start building resilience where we've got good practice, and we have loads of it. But particularly in the C&V sector, we're doing it with one arm tied behind our back. The demand for services outstripping what we can deliver, and I suppose the Department of Health core funding was another crash. The ENIC, National Insurances, we are coping with so many different, you know, unplanned for pressures on us, and yet we are still there in the evenings with the door open, because I can't close my door. I operate in the meadow in Uri. There's a population of 10,000 people in the houses around me. We're lucky if we can get the shutter closed and get to the car without somebody asking for a bit of advice, and that's real, tangible. That's life's not a spreadsheet. So when you say, what have you done in 2 years, Danny? I say fair play to you, but this is a really difficult. We were lucky enough to go to England and look at some models about, you know, a systemic care. It took them 12 years. I'm not suggesting we have 12 years to do this, because the crisis is now.
No problem, and I absolutely hear you, and the work you're doing is highly commendable. It's what I'm hearing from young people is the frustration. We've met the children, we've had them up here, we've had events for them, and they were really keen to be involved in the whole process. They're frustrated that, you know, there's young people who would have been involved in it that are now left the system.
Yes.
You know, and the frustration that they have had about this, at not seeing change happening.
Some of what we're trying to do is not easy to do,
and I appreciate that.
And there are resource challenges here. So, you know, we cannot create new children's homes, new smaller children's homes without additional investment. I don't think that we can support families in the way that we want to support them without additional investment. Now, I think over time you should be able to move money around a bit, but it will require at least some initial investment to be able to do these. So big problems to solve, Danny, and big challenges at play too, particularly around resource.
We have recommendations, and we hopefully will have a time frame then for the recommendations and the funding required.
Absolutely, everything will be costed. Absolutely.
And I think it's important to say that, I know you said none of the recommendations are completed, but it's not that they're not happening.
No, there is work.
There's an awful lot of work going on. It's just some of them are so massive, to develop and deliver on a family support strategy that's going to put tangible services on the ground for families and children to enable them to live safely at home. That's our goal. We want every child to have the best start in life and grow up within their communities of origin. We're doing an awful lot of work to make that happen, but it's going to take a wee while, and that's the issue. So when is that ever completed? When can you say that's done? Probably never. But when we start to see numbers of children that become known to social services or are in state care, where the state becomes their corporate parent, that's when we'll be able to know we're making a difference. But we have to turn this curve. And we're turning the curve, and we're using that old metaphor. We're flying the plane while we're building it. Because everything's happening at the same time, and Kerrylee's trying to manage the residential while we're trying to stop them going there in the first place. So
I appreciate it's a huge pressure, and huge jobs and huge changes need to be done. But it is good that we've got a map, and we are moving in that direction.
Yeah,
so
for
thank
sure.
you.
Thank you.
Eilís, thank you very much. Appreciate that. Okay, members. We're down to 4 members, so that we have no decisions that we can make.
Linda has her hand up there.
Linda, are you looking in?
It's okay, Chair, I can come back to it.
I was going to
Okay.
say that.
I mean, we're going to have. No, it's okay.
It's okay.
It's okay. We're going to have to come back to this next week because we can't actually.
Thanks very much.
Because there's only 4 of us, we can't actually make any suggestions about moving forward anyway. So we're going to come back to it next week.
That's okay. Yeah. Fine.
We can't do correspondence either. So just in terms of the forward work programme. So we can't do any of this. So we're just moving literally to item number 12. Date, time and place of next meeting, next Thursday, 12th of June, room 29, 2 p.m. So,
Are you allowed to decide that?
That's it.